Good afternoon, everyone. Today is day 4, and we will be dealing mostly with electrolytes and renal topics today. The first topic is by Dr. Abhilas, dyselectrolytemia.
Hello, am I audible?
Yeah, you're audible.
Sir, you're audible.
Good afternoon, everyone. Today I'll be dealing with major dyselectrolytemias, that is sodium and potassium disorders. So first is hyponatremia. Definition of hyponatremia based on biochemical severity. It may be mild, moderate, or profound. Mild is 130 to 135 millimoles per liter. Moderate is 125 to 129 millimoles per liter. Profound is less than 125 millimoles per liter. Definition of hyponatremia based on time of development, whether it is acute or chronic. Acute if it is developing within 48 hours, and chronic if it is developing more than 48 hours, in more than 48 hours. Then diagnostic algorithm. You have to see how to approach hyponatremia. So if the plasma sodium level is less than 135 millimoles per liter, then you see for the plasma osmolarity, whether it is more than normal plasma osmolarity or less than or equal, that is isoosmolar or hyperosmolar, or osmolarity is less than plasma. So hypertonic hyponatremia may be there, pseudo hyponatremia may be there, isotonic hyponatremia may be there. If that is hypotonic hyponatremia, then again you have to see for urine osmolarity. So accordingly you have to see for the causes of hyponatremia. If the urine osmolarity is less than 100, there are few causes like primary polydipsia, beer potomania. And if urinary osmolarity is more than 100, there may be then you have to see for the volume status. If there is volume depletion, that is hypovolemia or isovolemic or hypervolemic state. If volume depletion is there, there are few conditions. If isovolemia is there, there are few conditions like adrenal insufficiency, hypothyroidism, SIAD, thiazide diuretics, potassium depletion, that may cause hyponatremia. And in edema states, that is hypervolemia, there are few conditions that I will tell in the later slides. So in euvolemic hyponatremia, sorry. One minute, sorry. I think it is bit. Okay. So in isovolemic hyponatremia or euvolemic hyponatremia, one of the major causes syndrome of inappropriate antidiuretic hormone. So the extent of water ingestion exceeds the water elimination by insensible or GI or renal routes, leading to hypotonic hyponatremia. Because the normal response to extracellular hypotonicity is elaboration of the maximally diluted urine. In this condition, this dilution of urine is lost. So concentrated urine is there, even if the plasma volume is high. Means in isovolemic hyponatremia and in SIAD, there will be hyposmolar plasma but hyperosmolar urine. Urine need only be inappropriately concentrated, that is more than 100 milliosmoles per kg, to diagnose the SIAD. And before diagnosing SIAD, hypothyroidism and glucose insufficiency you have to rule out. And patient in whom the diagnosis of SIAD, as this is a diagnosis of exclusion, you have to be very sure about other concomitant causes of hyponatremia that should not be present. So essential criteria is, one is effective serum osmolarity is less than 275, hyposmolar plasma, urine osmolarity is more than 100, hyperosmolar or hypertonic urine, clinically euvolemic patient, urine sodium concentration is more than 30 millimoles per liter, with normal dietary and salt intake, absence of the adrenal, thyroid, pituitary, and renal insufficiency. And some supplementary criteria like serum uric acid less than 0.2 millimoles per liter, urea less than 0.3 millimoles per liter, suggesting of slightly hypervolemic plasma can also be present. So again, as I told, there are various causes of this hypovolemic and hypervolemic hyponatremia. If you see, assess the volume status, if there is hypovolemia, so the total body water is low, total body sodium is low, even lower, then you have to see for the urinary sodium, whether the loss of sodium and water is from urinary source or it is extra renal source. In the renal source, the renal causes are diuretic excess, mineralocorticoid deficiency, that is primary corticoid deficiency, salt losing deficiencies, bicarbonate like renal tubular acidosis, osmotic diuresis like glucose and mannitol, and cerebral salt wasting syndrome. These conditions, they will cause hypovolemic hyponatremia, and the source of loss is renal. And in extrarenal sources, vomiting, diarrhea, any third space loss, as in sepsis, pancreatitis, burns, these will cause hyponatremia due to extrarenal sources, and it is hypovolemic hyponatremia. If the body's fluid status is hypervolemia, means there is increased body water and even increase in the body sodium, but dilution will cause hyponatremia. Then again, you have to see urinary sodium, whether it is more than 20 or urinary sodium less than 20. If the urinary sodium is more than 20, definitely renal failure is there. The body is not able to retain sodium, so urinary loss is there. Acute or chronic renal failure. If the urinary sodium is less than 20, definitely nephrotic syndrome, cirrhosis, and cardiac failure. Other causes of hypervolemia are present, that is diluting serum sodium leading to hyponatremia. And as I told, in euvolemia, there is no edema. Total body water is slightly raised. Total body sodium is normal. And urinary sodium is always more than 20, as in glucocorticoid deficiency, hypothyroidism, CAD. These are all isovolemic hyponatremia. So how to start diagnosing hyponatremia? First, you have to see for the serum osmolarity to exclude pseudohyponatremia. Pseudohyponatremia, where it occurs in conditions where there will be obscuring of the measurement of sodium, like hyperproteinemias, like myeloma, and hyperlipidemia. These will lead to false evaluation of the sodium levels in laboratory. And elevated blood urea nitrogen creatinine also, we have to see to know the renal dysfunction. If there is adrenal insufficiency, whether it is present or not, or hypoaldosteronism is there, but you can know by increase of the potassium levels. Glucose levels should be measured, as you know, for every rise of 100 milligram per deciliter glucose, sodium falls by around 1.6 to 2.4 millimoles. So then measurement of uric acid can be done. As in CAD, the uric acid levels will be low, slightly low. Volume depleted patient will be hyperuricemic, and appropriate clinical setting should be there to diagnose the CAD, as thyroid, adrenal, pituitary function will be tested, and all are negative. Then only you can you can diagnose CAD as a condition. And in primary adrenal insufficiency, hypovolemic hyponatremia will occur. So urine electrolytes and osmolarity are crucial tests, like urine sodium less than 20, then extrarenal loss. If urine sodium is more than 20 or 30, it is renal loss of sodium. But ultimately, the gold standard for diagnosing the hypovolemic hyponatremia is plasma sodium correction after hydration with the normal saline. So thiazide-associated hyponatremia may present with higher than expected urinary sodium. One should defer making diagnosis of CAD until 1 to 2 weeks after discontinuation of the thiazides. Okay. So if thiazide diuretic patient on thiazide diuretics, you cannot diagnose the case as a CAD for at least 1 to 2 weeks. And you see the urine osmolarity, it is hyposmolar, less than 100. Then it is suggestive of polydipsia, primary polydipsia, or beer potomania. If the urine osmolarity is more than 400, then there is a syndrome of inappropriate ADH. So coming to the management of hyponatremia, it is according to symptoms, whether there is severe symptoms or not. Severe symptoms means okay. Severe symptom means patient will be comatose or GCS will be low, or there will be hemodynamic instability. If this patient come with this, then you have to go for the acute correction. Acute correction means the infusion of 150 ml of 3% hypertonic saline within 20 minutes. Then you have to check for the serum sodium concentration after 20 minutes and repeating the infusion of 150 ml of 3% NS for the next 20 minutes. Your target will be resolution of the acute symptoms or acute increase of serum sodium to 5 milliequivalents per liter. And you have to manage the patient with severe symptomatic hyponatremia in an environment where close biochemical clinical monitoring. Means you have to manage the patient at least in a SDU or ICU setting. Then follow-up management in case of improvement. If there is clinical improvement, means acute symptoms have subsided and there is a rise of 5 millimoles per liter sodium, then you have to stop the hypertonic saline. Then you have to start 3%, you have to start 0.9% normal saline, and you have to find out the cause of hyponatremia. That is the major step, because all the causes of hyponatremia, like drugs and any other cause, that has to be cured to get a good result. And they recommend limiting the increase of serum sodium concentration to a total of 10 per day in the initial 24 hours, and after that, every day at most 8 millimoles per liter, and the target sodium will be around 130 to avoid complications of overcorrection of sodium. And checking in the fast hour, then after 6 hours, then after 12 hours, serum sodium should be checked by sending the sample to lab. Then if the patient comes with moderately severe symptoms, what are the moderately severe symptoms? Like nausea, vomiting, and these are all moderately severe symptoms. Then we have to change our management plan little bit. That is, starting a prompt diagnostic assessment of the cause of hyponatremia. As in the severe symptoms also, you have to find the cause of hyponatremia and correct that cause. Then medications or other factors that contributed to hyponatremia, you have to stop that. Then they suggest immediate treatment with IV infusion of 150 ml of 3% NS. In the severe symptoms, they give 2 bottles. Here, they suggest only 1 bottle of 3% NS, that is 150 ml over 20 minutes. Then the acute rise, that is 5 millimoles per liter, it is same as severe symptoms. And every 24 hours also, there will be target of only 5 millimoles per liter per day rise, and up to 130 millimoles per liter, that is the target. And checking of sodium levels, that is same as 1 hour, 6 hour, 12 hours. So these two are how to start with hyponatremia treatment with 3% NS. Then after the acute correction and after elevation of the symptoms, correction guidelines of chronic hyponatremia are appropriate. You can use hypertonic saline. You know the hypertonic saline contains around 530 millimoles of sodium. Then you have to find the deficit of sodium. The formula is 0.6 into body weight into target plasma sodium minus starting plasma sodium. And if you, for example, if the sodium level is 120 and you target 130 and the patient is 60 kg, so 0.6 into 60, that is 36, and 130 minus 120, 10. So around 360 is the deficit, sodium deficit. In 1 liter of 3% NS, there is 510 millimoles. So for 360, around 400 ml of 3% NS is required. So once you have given the 3% NS bolus of 150, and the remaining 250 or 300 ml of 3% NS you have to give within 1 or 2 days according to your calculations. So increasing the plasma sodium concentration can be highly unpredictable during treatment. So you have to be careful. So chronic hyponatremia, they are at high risk of osmotic demyelination syndrome if plasma sodium correction is more than 8 to 10 millimoles within 24 hours or more than 18 millimoles within 48 hours. So response to intervention of hypertonic saline, acetonic saline can be highly unpredictable. Frequent monitoring is required. After correction of plasma sodium, focus should be on the treatment and withdrawal of the offending cause. This is all about hyponatremia. Coming to hypernatremia. So it can occur in 3 states. One is with normal total body sodium, one with low total body sodium, one with high total body sodium. First is hypernatremia with low total body sodium. These patients sustain losses of both sodium and water, but with a relatively greater loss of water. They manifest as signs of hypovolemia, like orthostatic hypotension, tachycardia, neck veins will be flat, poor skin turgor, dry mucous membranes, and altermentation. The cause reflect primarily hypotonic water losses from the kidney or GI tract. And hypernatremia with increased total body sodium, this is the least common form. It may result from hypertonic solutions like 3% NS, administration of sodium bicarbonate for treatment of metabolic acidosis, hyperkalemic conditions, and cardiac arrest conditions. This may also happen accidentally in dialysis against a high sodium dialysate. When this is used, accidental sodium levels will be high, and hypervolemia will also be there. And hypernatremia with normal total body sodium. Most patients with hypernatremia secondary to water loss appear euvolemic with normal total body sodium, because loss of water only without sodium does not lead to overt volume contraction. Water loss per se need not culminate in hypernatremia unless it is accompanied by water intake. So most of the times, only water loss will not cause hypo or hypernatremia. And hypodipsia is uncommon. Usually, hypernatremia usually supervenes where there is no access to water, or in neurological deficit patients that will not allow the patient to have water when there is water loss. That will lead to hypernatremia. Extrarenal water loss occurs from the skin and respiratory tract in febrile or hypermetabolic states. This will lead to isovolemic hypernatremia. The defense against the hyperosmolarity requires both the stimulation of the thirst and even the ability of the drinker to have water. The renal losses of water can lead to euvolemic hypernatremia, are a consequence of either defect in the vasopressin production or release, that is central diabetes insipidus, and failure of collecting duct to respond to the hormone, that is nephrogenic diabetes insipidus. As diabetes insipidus is very common in ICU, and it is a major cause of hypernatremia. So who are all the patients? They are in increased risk of hypernatremia. One is elderly patients and infants. One is inpatient who receive hypertonic infusions, tube feeding, osmotic diuretics, lactulose, and patient with mechanical ventilation. They are prone for hypernatremia. Patient with altered mental states who are not supposed to drink water when they are thirsty, and uncontrolled diabetes insipidus due to osmotic diuresis can cause hypernatremia. Polyuria conditions. So what are signs and symptoms? Majorly neuro and muscular signs. In neurological signs and symptoms, altermentation can occur, lethargy, irritability, restlessness. Sometimes seizure can also occur. And in neuromuscular symptoms, muscle twitching can be there, hyperreflexia can be there, spasticity can be there. So diagnostic approach, you have to first assess the volume status, as in hyponatremia also. In hypernatremia, volume status is very important, whether patient is hypovolemic, euvolemic, or hypervolemic. In hypovolemic patients, you have to see for the loss, whether urinary loss or extra renal loss. If urinary loss of sodium is more than 20, it is renal loss, maybe due to osmotic diuresis or loop diuretics. Post-obstruction polyuria can occur, and it leads to dehydration and hypernatremia, or some intrinsic renal disease can cause hypernatremia. If extrarenal loss of sodium is there due to excessive sweating, burns, diarrhea, fistula, that will lead to hypovolemia and hypernatremia. And hypervolemic hypernatremia due to sodium gains, mostly primary hyperaldosteronism, Cushing syndrome, hypertonic dialysis, hypertonic sodium bicarbonate, and sodium chloride tablet injection. And in euvolemic hypernatremia, urinary sodium may be variable, maybe due to renal losses or external losses. Renal losses, majority is diabetes insipidus, central or nephrogenic, and hypodipsia in psychiatric patients. And external losses due to insensible losses, like in ventilator patients, respiratory losses, and dermal losses. So treatment of hypovolemic hyponatremia. Correction of the volume deficit, isotonic saline until the hypovolemia improves. Treatment of the cause of volume loss, like insulin in diabetes mellitus, relief of obstruction in all the obstructive uropathies, removal of the osmotic diuretics. Then correction of the water deficit. calculation of the deficit is important, and accordingly 0.45% normal saline, 5% dextrose or oral free water replacement can be done for the deficit and for the ongoing losses. Treatment of hypervolemic hyponatremia, first thing is removal of sodium by diuretics or dialysis. Diuretics like furosemide can be helpful, or dialysis, and discontinuation of the offending agent like 3% NS or sodium bicarbonate, whatever, or that sodium chloride tablets. So treatment of euvolemic hypernatremia, correction same as the hypovolemic, that is correction of the water deficit. You have to calculate the deficit, then you have to use 0.45 saline or dextrose or normal water. And in central diabetes insipidus with severe losses, you have to use vasopressin. You have to monitor the serum sodium levels, and also you have to use long-term therapy like Vaptans. You have to use long-term therapy like some drugs. Now coming to diabetes insipidus. It may be central or nephrogenic. Central diabetes insipidus occurs in around 50% of cases, that is idiopathic in origin. Some diabetes insipidus is caused by tumors like metastatic tumors, trauma to the head, or granulomatous disease like tuberculosis, sarcoidosis, and meningitis, encephalitis can also cause central diabetes insipidus. Symptoms include polyuria, polydipsia, nocturia, high serum osmolarity, and low urine osmolarity. Just reverse of syndrome of inappropriate ADH. There, urine will be high osmolar and serum will be low osmolar. In diabetes insipidus, serum will be high osmolar, urine will be low osmolar. Congenital nephrogenic diabetes insipidus can be present, or acquired nephrogenic diabetes insipidus can also be present. In congenital nephrogenic diabetes insipidus, there will be receptor deficiency, that is B2 receptor defect or aquaporin channel defect, that will lead to congenital nephrogenic diabetes insipidus. And acquired nephrogenic diabetes insipidus can occur in chronic renal insufficiency due to any cause like tubulointerstitial diseases, sickle cell disease, or analgesic nephropathies. And two conditions, hypokalemia and hypercalcemia, also can cause acquired nephrogenic diabetes insipidus. So treatment of the central diabetes insipidus is desmopressin. If there is complete damage, the desmopressin will be given intranasal 10 to 20 microgram. And if partial central diabetes insipidus is there, vasopressin can be used like aqueous vasopressin, and some drugs like chlorpropamide, carbamazepine can also be helpful. In nephrogenic diabetes insipidus, major thing is the reversal of the offending agent, that is correction of the potassium levels and calcium levels, removal of the offending drugs, low sodium diets, thiazide diuretics, and amiloride also can be helpful in nephrogenic diabetes insipidus patients. Coming to hyperkalemia. Plasma potassium levels more than 5.5. It occurs in around 10% of hospitalized patients. Severe hyperkalemia is more than 6 milliequivalents per liter seen in 1% of patients. So who are all the high-risk patients? Patient with diabetes mellitus, CKD patients, patient with AKI, cardiovascular disease patients. They are on multiple drugs, and they have conditions that lead to hyperkalemia due to redistribution, decreased secretion, and increased intake. Okay. So coming to the causes, pseudo hyperkalemia may be one of the rare cause, and other causes like cellular redistribution in metabolic acidosis, hypertonicity due to mannitol and or insulin deficiency, beta blocker therapy, alpha adrenergic stimulation, hyperkalemic periodic palsy, and cell injury that will lead to hyperkalemia due to potassium moving out of cell. And excess intake will also lead to hyperkalemia, but this occurs almost always in the setting of impaired renal potassium excretion. Means in renal failure only, this excess intake will cause hyperkalemia. And another cause is decreased renal excretion in renal failure patient one is due to decreased distal delivery of sodium like oliguric renal failure, acute kidney injury, mineralocorticoid deficiency states, primary or secondary, and defect of the cortical collecting tubules. So metabolic acidosis and hyperchloremic acidosis, there will be impermeability of the cell membrane to the chloride ion, and electrical neutrality is maintained by the potassium exit from inside cell to the extracellular fluid. And in other organic acidosis, these organic ions readily cross the cell membrane along with the hydrogen. They will come outside the cell. And in lactic acidosis, there will be cell integrity loss that result due as a result of ischemia, and there will be loss of potassium from the cell. And in diabetic ketoacidosis, insulin deficiency and hypertonicity will cause drag of potassium from intracellular space to extracellular space. This will cause hyperkalemia. So what are all the drugs causing hyperkalemia? Drugs causing defective aldosterone signaling like beta blockers, NSAIDs, ACE inhibitors, ARBs, heparin, this will cause hyperkalemia. Some drugs causing defective distal electrogenic sodium reabsorption like amiloride, all the diuretics like amiloride, triamterene, trimethoprim also can cause hyperkalemia. Cellular potassium translocation like alpha agonist, beta blockers, digitalis, succinylcholine, mannitol, they will cause hyperkalemia. And some exogenous potassium load, that is penicillin, can cause this hyperkalemia. So clinical feature of hyperkalemia is in ECG you can see peak T waves, then wide PR intervals, widened QRS, peak, and then this ECG change can lead to sine wave pattern, loss of P wave, and finally cardiac arrest. And in neuromuscular manifestations, there may be paresthesia and fasciculation in the arms, legs, ascending paralysis with eventual flaccid quadriplegia can also occur. So coming to the management, hyperkalemia can be managed according to the state, that is acute or chronic. If it is acute, then IV calcium, insulin glucose, nebulized salbutamol, sodium bicarbonate, diuretics, hemodialysis can be done. And if it is chronic, dietary potassium counseling should be done. You have to manage the RAS inhibitory therapies, and effective diuretic therapy can be done, and oral sodium bicarbonate can be given along with potassium binders. So these are all the agents for acute hyperkalemia. IV calcium, immediate effect within 30 to 60 minutes duration, insulin glucose 15 minutes, beta 2 agonist 30 minutes, sodium bicarbonate 30 minutes, diuretics 5 to 15 minutes. Now coming to hypokalemia. Causes of hypokalemia. Sorry, first is mild, moderate, severe. Mild is 3 to 3.5 milliequivalents per liter. Moderate is 2.5 to 3 milliequivalents per liter. And severe is less than 2.5 milliequivalents per liter. And the causes are, one is redistribution, one is renal loss, one is extrarenal loss. Redistribution may be due to hyperthyroidism, metabolic alkalosis, hypothermia, drugs like beta agonist, catecholamines, insulin. And renal losses is due to diuretics like loop and thiazide diuretics, glucocorticoids, aminoglycosides, amphotericin B, renal tubular acidosis. External losses like diarrhea, vomiting, nasogastric drainage, and ileostomy can also cause hypokalemia. So in hypokalemia, there will be slight PR prolongation, ST depression, prominent T waves. In respiratory manifestations, there will be muscle weakness, respiratory failure, muscle cramps, rhabdomyolysis, myoglobinuria can also occur. So approach to hypokalemia, if patient is coming with hypokalemia, whether it is pseudo hypokalemia or not, then if it is true hypokalemia, whether it is life-threatening signs and symptoms or not, if life-threatening signs and symptoms are there, then you have to treat first. And if it is there is no life-threatening symptoms, then you have to see for the urinary potassium, whether there is loss of potassium in urine. If it is less than 15 millimoles per day, then there is no loss of potassium in urine. Then you have to see for the acid-base status. Patient is having metabolic acidosis or alkalosis. If patient is having metabolic acidosis, mostly GI source is the cause of loss of potassium, and metabolic alkalosis may be due to vomiting, diuretics, nasogastric drainage. Then if there is urinary potassium loss that is more than 15 millimoles per day of potassium is going in urine, then you have to see for the transtubular potassium gradient, TTKG. TTKG is more than 3, then you have to see the blood pressure of the patient, whether he is normotensive or hypotensive or hypertensive. If patient is normotensive, then whether there is metabolic acidosis or alkalosis. If patient is having metabolic acidosis with low blood pressure or normal blood pressure, diabetic ketoacidosis or renal tubular acidosis may be the cause of hypokalemia. And patient having metabolic alkalosis, then you have to see for the urinary chloride loss. If urinary chloride is more than 10, that is loss is there with chloride in urine, then Bartter-Gitelman may be present, or some diuretics can cause loss of chloride, leading to metabolic alkalosis and hypokalemia. And if urinary chloride is less than 10, so renal loss is not there, vomiting may be the cause. And in patient with TTKG of more than 3 and high blood pressure, you have to measure the aldosterone and renin levels. If aldosterone is high with renin high, the patient may be having renin secreting tumors or renovascular diseases or some malignant hypertension. If the aldosterone is high and renin is low, primary aldosteronism may be the cause of hypokalemia. And if aldosterone is low and increased cortisol, Cushing syndrome, and if aldosterone is low and normal cortisol, Liddle syndrome may be the cause of hypokalemia. So management of hypokalemia, we have to identify the cause of hypokalemia to stop the ongoing losses. Asymptomatic patient, oral potassium supplementation can be done. Symptomatic patient, IV potassium supplementation. Maximum rate is up to 40 milliequivalents per hour in unstable arrhythmias. Correction of the magnesium deficiency. Then 4 types of potassium preparation are there. One is potassium chloride, one is potassium phosphate for concomitant hypophosphatemia, potassium citrate or potassium bicarbonate for the concomitant metabolic acidosis. Thank you.
Thank you, Dr. Abhilash. The next presenter is Dr. Rupali. She will be telling about upper GI and lower GI bleeding.
Good afternoon, everybody. Am I audible? Should I start?
Yes, audible.
I'll be talking on upper and lower GI bleed. Yeah. Coming to overview, I'll be on definition and classification, epidemiology, etiology features, clinical features of this, complications, diagnosis, then the management aspect. Anywhere into the GI tract, the GI bleed, but depending on the location of the ligament of treat, it is upper GI bleed or lower GI bleed. This is above the ligament of treat, then upper GI, and below it is the lower GI bleed. Incidence upper GI bleed is higher incidence compared to the lower GI bleed, almost 5:1, and the mortality rate due to upper GI bleed is more common compared to the lower GI bleed. Upper GI bleed mainly most common cause is the peptic ulcer diseases. Patients on antiplatelet therapy or anticoagulant therapy, they are higher risk and their prognosis is bad compared to other populations. Coming to upper GI bleed first, they are divided into causes very cell bleed. Bleed is most common cause. Others are esophagitis, gastritis, erosive duodenitis, upper GI tract tumors, vascular ectasias, portal hypertensive gastropathy, medullary waist tear, or obscure upper GI bleed. Various duodenal causes can be duodenal ulcer, vascular malformation like aortic enteric fistula, hematobilia, bleeding from the biliary tree, hemococcus pancreatitis or bleeding from the pancreatic duct, and pancreatitis with complications like pseudoaneurysm and trauma surgery too. These are also causes of duodenal causes. Severe superior mesenteric artery syndrome and periampullary carcinoma. Here in the picture it is showing the major causes of duodenal bleeding. In peptic ulcer, it is mainly disruption of the mucosal barrier and its direct inflammatory effect on gastric and duodenal mucosa. This is the pathophysiology of peptic ulcer disease. Not going into detail, mainly the NSAIDs are the main culprits, those who are taking it regularly, and H. pylori is associated with it. The first classification for the upper bleed is the peptic ulcer disease bleed is the 1A to 3. 3 is clean base. 1 is the when arterial is jet-like bleeding as per the severity. It is 1 is like jet-like bleeding, 1B is oozing, 2A is visible vessel, B is adherent clot, 2C is flat pigmentation, and 3 is clean base. Then others are medullary waist. Medullary waist is submucosal laceration that occur at the gastroesophageal junction, usually distal into hiatal hernia. This is here in the picture. It is showing how the tear it is in the gastroesophageal junction. This is in a single tear that begins at the gastroesophageal junction. Then erosive gastritis, stress-related mucosal damage, SRMD, and causes other like aspirin and NSAID use regularly that leads to stress-related mucosal damage. The various causes like trauma, surgery, burn, and intracranial disorders like stroke, these patients are high risk for stress-related mucosal damage. Then portal gastropathy. It is like portal hypertensive gastropathy, increased portal venous pressure and severe mucosal hyperemia. Here in the picture, it is in another cause is portal hypertensive gastropathy. Then Dalfras lesion, it is a large submucosal artery that protrudes through the mucosa. It is not associated with peptic ulcer, but it leads to massive bleeding, usually located at the gastric fundus within 6 centimeters from the gastroesophageal junction. This is difficult to identify at endoscopy because of this leads to intermittent nature of bleeding. And overlying mucosa may appear normal, but this is important cause of the bleeding, which lead to torrential bleeding also. This endoscopic Doppler ultrasound found to been used to found this lesion. It is found and endoscopic hemostasis is achieved with this lesion found. Then gastric enteral vascular ectasias. These are also another causes. Rarely various causes of upper GI bleed. It is one of the cause. Then aortoenteric fistula. Bleeding is very massive and high mortality rate. Aortoenteric fistula communication between abdominal aorta and enteros, that is duodenum mainly. And so it is these patients are very high risk for bleeding and they sanguinate like anything. So they are candidates for surgical intervention also. Another rare cause is Cameron's lesion, linear erosion ulceration in the proximal stomach, okay, near the diaphragmatic bridge. Then comes the varicose bleeding. After the non-varicose causes, there comes the varicose causes. Most common causes portal hypertension. Initial factor portal hypertension increase in vascular resistance that leads to varix formation, the structural destruction and varix formation. This due to development of portosystemic collaterals that bleed. This is the causes of varicose bleed. Hepatic venous pressure gradient is more. This leads to varicose bleeding more than 12 mmHg. Is the portal hypertension. Clinical features of bleeding linked to hematemesis, bleeding of vomiting of fresh old blood or bright red blood or coffee ground hematemesis. If there is no active bleeding, melena, hematochycha, and occult bleeding. Occult bleeding when there is not apparent and may lead to other clinically these patients are hemodynamic unstable, but they do not present with bleeding. And the various causes I have shown, the cause of upper GI bleed, not going into detail. And for this alcoholic liver disease, cognitive disorder, and associated with it. Then examination vitals or systemic examination, then skin changes for cirrhosis patients and coagulation disorder patients, and also ENT is important for look for the clots, example epistasis that can mimic sometime to bleeding. Then how to approach these patients? It initial assessment, then stabilization. Then we have to identify the bleeding source, to stop active bleeding, then treat the underlying cause, then prevention of recurrent bleeding. Then initial assessment and trials, various scorings are there. Pre-endoscopy scoring system and post-endoscopy scoring systems are there. The pre-endoscopy is the Blatchford score. Here, this is the score. If the score is more than 6, then high risk of needing an intervention. Okay, various parameters like blood urine nitrogen, hemoglobin, and blood pressure, and all other parameters are there. These are like history of hepatic disease, cardiac failure. Then more than 6, that is high risk for intervention. The occult source is risk of rebleeding and death after admission to hospital for acute GI bleed. This is also if increase in Ruckle score, then more than 8, in fact, that is increased risk of bleeding. High risk of death in patients with higher, more than 8, it is high risk of death. Then general management, ABCD management, along with that, the need of blood and blood products and fluid resuscitation. Then comes the medical management for upper GI bleed, proton pump inhibitors. This is for upper GI bleed. The mainly pantoprazole are preferred compared to the H2 antagonist or supralphate. Then comes octreotide or stomatostatin. Obviously, octreotide is, one will think for varicose bleeding only, but it is role in the non-varicose bleed also. It is suggested at the administration of this analog octreotide or somatostatin analog octreotide decreases the rebleeding from the peptic ulcer disease compared to placebo or H2 blockers. If it is not still despite use of PPI, there is bleeding, then can use the octreotide also in non-varicose bleed. Then identify the bleeding source. The gastric lavage. The point of gastric lavage is with is to clear the for endoscopic visualization is better, and estimation of how bleeding is rapid. That is only gastric lavage. Either use of saline, it leads to proper visualization during endoscopy. Then comes the endoscopic intervention. Endoscopic is urgent or elective. Urgent is less than 12 hours. There is torrential bleed, and elective within 24 to 48 hours of rebleeding, patients are hemodynamics are maintained. The various endoscopic therapies like injections therapies, thermal therapies, and mechanical therapies are going. I'll go one by one. Okay. Then injection therapies, like primarily we use the epinephrine, 1:10,000, 1:20,000. Then thermal therapies, the non-contact thermal therapies or mechanical therapies. The injection therapies is like it reduces blood flow by local tamponade effect in injection of 0.5 to 1 ml of helicars of epinephrine, 1:10,000 to 20,000 by sclerotherapy needle 4 quadrants of the ulcer. Other sclerogents can be ethanolamine or polydocanol. These can also be used. Then thermal therapy. Thermal therapy using monopolar or bipolar cauteries are very much helpful. These are low voltage, 10 to 15 watts, 15 to 20 watts is the used with these cauteries. There is this thermal lead to coagulation, protein coagulation, and hemostasis is achieved the area. Then mechanical therapies. Therapy of choice in obvious arterial bleeding. It like hemoclips are applied there in the and various combination of therapies also. Then non-contact thermal therapies are like laser therapies. These are YAG laser, argon lasers, but lasers are not preferred these days because of high cost and complications associated with the laser technique. Argon plasma coagulation, APC. It is the argon gas which forms a plasma that acts as electrical conductor. It coagulates the superficial tissue, and treatment of superficial lesions only argon plasma coagulation is being used. Then mechanical therapy is like which causes mechanical clips used, the rubber or bend ligation or endo loops. The metallic clips are most commonly used. This causes physical tamponade of the bleeding side. Then hemostatic spray. This is a new modality. It is an absorbent powder that rapidly concentrates the clotting factor at the bleeding side, but easy to use. Difficult areas also it is accessible and able to treat the large surfaces. Then various angiographic therapies. After endoscopic therapies, then comes the angiographic therapies. These are reserved when endoscopy is not possible, or despite endoscopy there is still bleeding, or endoscopic therapy is failed. Then angiographic technique has to use. Angiography or transcatheter techniques. They use either infusion of vasoconstrictors like vasopressin, but it is less preferred because of other complications, or it can be due to, or it can lead, work by use of embolization, the mechanical occlusion. Transcatheter embolization is mainstay of therapy of the angiographic techniques. The embolization material can be temporary using gelatin or autologous cloth, or it can be coiling. Then comes the surgical therapies when it is not available for endoscopic therapy, not being controlled after angiographic therapy also. Then surgical therapy is less preferred, but these are options like truncal vagotomy with enterectomy, truncal vagotomy with pyloroplasty, or total gastrectomy. Varicose bleed. After non-vagal bleed is the varicose bleeding. Varicose, obviously, medical management is the use of vasoconstrictors. Vasoconstrictors are these mainly splanchnic vasoconstrictors. The vasopressin is less preferred. Vasopressin is like both systemic vasoconstrictor, that is other side effects of it. But vasopressin along with use of nitrates have been recorded. Then terlipressin, which is a vasopressin analog, which is preferred. Dose is 2 mg bolus followed by 1 mg every 6 hourly for 3 to 5 days. It is a vasopressin analog is helpful for the varicose bleeding. Then stomatostatin can be used also, and somatostatin analog is octreotide is preferred. The dose can be 50 max bolus followed by 50 max per hour infusion for the 3 to 5 days. Mainly toliprazine or octreotide is useful, which is specific sparkling vasoconstrictor. Then pressure techniques like these are tubes like esophageal balloons like Blackmore tube, Minnesota tube, and Linton Nicholas tube. These are the three used. This is should be inflated for less than 24 hours. Okay? And 70% rebleeding after it is main side effect is after deflation. There is high chance of rebleeding, and also it is associated with various side effects like patients can develop aspiration, then esophageal rupture, and airway obstruction also. Though bleeding is controlled, so it should be reserved for the torrential bleeding and also when other options are not available or not being feasible. Then endoscopic sclerotherapy for the varicose bleed. The various sclerogents are like ethanolamine, polydocanol, or sodium tetradecyl sulfate are used. The tissue adhesive glues are there. These are sclerotherapy using these sclerogents, which is called protein coagulation, and these varices are being the varicose bleeding is being stopped. Then hemostasis is achieved with very high rate of with this, but rebleeding rate is late. But these sclerogents has complications like can lead to esophageal ulcers, esophageal stricture formation, pleural aspiration pneumonia, and mediastinasis, even esophageal perforation. So compared to endoscopic sclerotherapy, preferred is the endoscopic varicose vein ligation for varicose bleeding. Vein ligation, what is vein ligation? It is a rubber band is placed over the varix, which is subsequent undergo thrombus, flowing, and fibrosis. Here in the blue are the bands. In at the tip of the endoscope, it is placed. It is like the binding the rubber band, ligating the rubber band. At least these multiple bands can be used at a time. 5 to 6 bands can also be used. Here, this is the banded varix. How two bands are placed at the varix, and it is being banded. It is preferred from the endoscopic sclerotherapy. Then comes like the non-varicose bleed. Here also options like angiographic and surgical aspects. Angiographic mainly angioembolization is preferred either with the glue or with the permanent coiling. Then various surgical techniques for the varicose bleed also available. This angioembolization with the glue, the arteries are being embolized, bleeding arteries. Then transucular intrahepatic photosystemic shunt tips. It was previously used very now not yet preferred. Tips is it is like creation of low resistance channel between portal and hepatic channel. Now we have to create the photosystemic shunt with low resistance channel. In acute varicose bleeding refracted to endoscopic and pharmacological technique, this is preferred. Bleeding is very well controlled with the tips procedure, but there is less risk of rebleeding. Rebleeding risk is less than 20%, and bleeding control is more than 90%. But it is associated with complications like high mortality rate after the procedure, and patients develop they land up into hepatic encephalopathy, stenosis, and occlusion of the shunt are the other side effects. There are surgical options like photocaval shunt, distal splenorenal shunt also preferred for the varicose bleed, but these are last resort options when others are not feasible. Mainly endoscopic therapies are preferred in both varicose and non-varicose causes of the upper GI bleed. Then some other causes like Mallory-based step, it is endoscopic electrocoagulation of the tears are treatment of choice, and angiographic with embolization also. Portal hypertensive gastropathy, mainly beta blockers are used, TIPS procedure, and endoscopic management. Then vascular ectasias, endoscopic therapy with argon plasma coagulation, and aortic enteric fistula, mainly surgical management. This is the flow chart, not going into detail up to how to manage for the upper GI bleed, okay, like gastric lavage, and first is hemodynamics management, and with the medical therapy here coming into picture. Then for peptic ulcer disease, high risk of rebleeding, endoscopic treatment, and low risk of rebleeding, the medical management. And for varices, endoscopic treatment and medical management. If still bleeding continues, then only these are for candidates for the angiographic and surgical intervention also. Then one is obscure upper GI bleed. It is like when there is a diagnostic not being evident, like when stool alcohol blood is positive, but they are not evident blood is there. And various diagnostic like enterocyclis, technetium level, nuclear scan, CT angio, these are capsule endoscopy, these are the various diagnostic modalities. When there is obscure upload GLP, there is drop in hemoglobin, there is occult blood positive, but but these patients not have evident bleed. Then management is angiography or enteroscopic or angiographic management is mainly preferred. Then comes some slides of lower GI bleed. Lower GI bleed, bleeding distal to ligament of breast. It is when acute is less than 3 days, chronic when extending over period of several days. It is arbitrarily defined. The sources of lower GI bleed, it can be diverticulitis, or angiodysplasia, cancers, polyps, or colitis, or various causes. And diverticulitis is the most common cause. I'll go one by one. Very less slides are there. Diverticular bleeding is most common source for lower GI bleed. Mainly 40% contributed by elderly patients present with painless hematochezia and repeated trauma to vasa recta that stretch over diverticular door is the lead to diverticular bleeding. NSAIDs increase the risk of diverticular bleed. Then comes the angiodysplasia. This is the second most common cause. Elderly patient with painless bleeding. Elderly patient with painless bleeding. Endoscopic red flat lesion with ectatic blood vessel radiating from the central feeding vessel. Endoscopic treatment is highly effective here. Here it is the red flat lesion with ectatic blood vessel radiating from the feeding vessel. And after the thermocoagulation, this is the picture of the angiodysplasia. Then other causes like ischemic or other colitis, reduction in the mesenteric blood flow is the main causes. It contributes to almost 19 to 20% of the lower GI bleed. Opposed to acute, it's transient and reversible. Watershed areas of the colon are affected, like splenic flexure and ectosigmoid junction. Abdominal pain and with bleeding is the major manifestation. Others like angiodysplasia and diverticulosis are painless causes. And endoscopy, that is necrotic cyanotic mucosa. Supportive therapies are main therapies. Surgery for chronic chronic ischemic colitis that leads to stricture formation with this surgery. Infectious colitis, radiation colitis, or inflammatory bowel disease are other causes of colitis. The other causes can be polyps, cancer, or anorectal sources like hemorrhoids, proctitis, and anorectal fissures. And small bowel sources are basically difficult to identify. The diagnosis is like colonoscopy, radionuclide scanning, angiography, and CT scan or CT angio. And therapies are endoscopic, angiographic, and surgical therapies like colonoscopic, angiographic, and surgical therapies aging the upper GI bleed. Thank you.
That's very well presentation, ma'am. Rupali, ma'am. Without any delay, we'll switch on to next speaker. That is Dr. Rohit Patnaik, sir. He will be talking about acute liver failure. He is associate professor in Department of Critical Care Medicine, IMS in some hospital. Sir, Rohit, sir, after you, sir. Please start the presentation.
Thank you, Chandramouli. Yes, sir. Yeah, my slides are visible?
Yeah, they're visible.
Okay, good evening, everyone. So my topic for today is acute liver failure.
Please start. Yeah, they're visible, sir.
Yeah, my topic for today is acute liver failure. So the definition of acute liver failure. So first and foremost thing, we have to differentiate what is acute liver failure versus what is chronic liver disease. And the other third entity is basically acute on chronic liver failure. So these are three entities which are there. Acute liver failure is a very acute thing where you have to where it is defined as the time between the jaundice and the encephalopathy being less than 28 days. So it is a very acute thing. What happens in chronic liver disease is basically a chronic insult to the liver in terms of alcohol or viral hepatitis, where this patient has got lots of fibrotic changes happening in the liver and ultimately leading to chronic liver failure. Acute on chronic liver disease or acute on chronic liver failure or ACLF is a condition where there is an acute decompensation of a chronic liver disease that due to a very acute thing such as an infection, and that has a very high short-term mortality as well. So these are the three entities you need to first understand. So today's topic which I am dealing with is basically acute liver failure. I will not be touching on CLD or on ACLF. So that is the first thing that I have to be clear on. So basically, acute liver failure is acute abnormality in liver blood tests in an individual without any chronic underlying liver disease, any underlying chronic liver disease. This is the first and most important thing. And if you see here, acute liver failure is basically defined as coagulopathy, jaundice, and encephalopathy. So if you have coagulopathy and any degree of mental alteration or encephalopathy in a patient without having any pre-existing cirrhosis, with an illness of less than 28 weeks. This is the golden number you sort of have to remember when you remember the definition of acute liver failure, that it has to be less than 28 weeks. So if you see here, the classification from O'Grady, this is the age-old classification that we are still following. There are several other classifications that also have come up. Some of the Chinese authors have also brought up few classifications, but this is the one that is standard and even used even in today's day and age. Basically, you have jaundice to hepatic encephalopathy, the duration, which determines the sort of spectrum of acute liver failure that you are dealing with. So in the spectrum of acute liver failure, you can have hyperacute liver failure, you can have acute liver failure, or you can have subacute liver failure. Remember, this is all under the spectrum of the broad term of acute liver failure. This is not under chronic liver disease. So in this classification system, if you see, if you have a patient who's got hyperacute liver failure, then your jaundice to hepatic encephalopathy duration is basically less than 7 days. If you have a patient who's got acute liver failure, in the truest sense, it is somewhere between 8 to 28 days, the time between jaundice to hepatic encephalopathy. And if you have subacute liver failure, the amount of time is more than 28 days from jaundice to hepatic encephalopathy. So basically, if you see the characteristics of each of these conditions, hyperacute liver failure is the one that presents more commonly with cerebral edema. And these patients are actually also recover very well, and they don't need a liver transplant also several times. Acute liver failure is somewhere in between the hyperacute and the subacute. Whereas in the subacute liver failure, basically the cerebral edema is extremely uncommon, whereas the portal hypertension starts coming up a little bit. And the survival chances without a liver transplant are extremely less. So basically, on one end of the spectrum, we have hyperacute liver failure. On the other hand, we have subacute liver failure. And in between, we have this acute liver failure, which is there. So in a broadest sense, these are all under the definitions of acute liver failure. So patients might present to you from jaundice to hepatic encephalopathy in various durations which are there. One of the other things we have to remember is sometimes toxin-associated acute liver failure, such as paracetamol or mushroom poisonings, can present without having the jaundice and the prodromal illness with nausea and vomiting. They can directly present to you with hepatic encephalopathy, and probably they might even develop jaundice a little later. So that's why your history is so important, where we have to understand that such toxin-related acute liver failures can present with non-classical presentations where you have jaundice to hepatic encephalopathy durations might not even be there. That is, the hepatic encephalopathy might be the only manifestation which might be there. Coagulopathy might be there, but jaundice might come later in such toxin-related acute liver failures. Moving forward, the etiologies of acute liver failure. The first and foremost, viruses. Quite a few hepatotrophic viruses. But remember, you have to understand that some of the viruses cause acute liver failure, whereas others cause chronic liver disease. And in acute liver failure, hepatitis A and B are the ones that are the more notorious, even hepatitis E to a certain extent. But hepatitis C is the one that causes chronic liver disease and very rarely causes acute liver failure. CMV, HSV, EBV are all causes of acute liver failure in immunocompromised patients. If you see the toxins, I mentioned about few of the toxins. One of them I told was paracetamol. The others are mushroom poisoning. And then others include, in our setups, include yellow phosphorus poisoning. So this is an extremely, this is the rat poison that people keep in their homes and they take and come. This is yellow phosphorus. And what about pregnancy related? In my previous lecture yesterday, in the last week, I talked about acute fatty liver of pregnancy and HELP syndrome. These can also present as acute liver failure. And the vascular causes, you can have ischemic hepatitis, severe hypotension, which can present, and hypoxia. Patients might come with acute liver failure. Patients might have thrombotic episodes such as portal vein thrombosis, hepatic arterial thrombosis, and Budd-Chiari syndrome. These all can cause acute liver failure. Most importantly, and the most important cause which has been seen to cause acute liver failure in the United States is basically the paracetamol poisoning. This is the one which is the most common cause of acute liver failure. So if you see, what are the hepatotrophic viruses which cause acute liver failure? I mentioned about hepatitis A, B, D, and E. Hepatitis C, usually chronic liver failure, but it can come up as acute liver failure sometimes. HAB and HBV are the major causes. What about paracetamol? We've seen that no prescription drug is known to have caused so many deaths and near fatal episodes as paracetamol. Why is it so? Because it has got a very narrow therapeutic window. What are the risk factors? We have to understand. Not every patient with a high dose of paracetamol presents with acute liver failure. So we have to understand that paracetamol should have caused a high blood level. It should be an adult patient. Doses which are more than 7.5 gram of intake. Patients who have got chronic alcohol ingestion, where in the background of this alcohol ingestion, paracetamol has been taken in high doses. Patients who are fasting, patients who present late to you or with delayed treatment, which is more than 16 hours later, they present to you. And patients who take concomitant hepatotoxic medications such as INH, phenytoin, phenobarb, zidovudine. These patients are also at risk of drug-induced liver injury. And in the background of that, they have this paracetamol as well. So these are all the risk factors which can cause paracetamol toxicity and acute liver failure. So what do we do about it? If you see here, first we need to understand paracetamol, how it causes, what are the problems, how it causes the toxicity. Normally, acetaminophen or paracetamol, if you see 90% of the paracetamol is usually metabolized with these two pathways, which is conjugation, which is mentioned here in both sides. They get metabolized into glucuronide and sulfate moieties, which are non-toxic. Approx 5% of the metabolism goes towards the production of NAPQI, NAPQI. This is the metabolite which is toxic. Under normal conditions, you have good amounts of glutathione in your body, and this will have GSH transferase and production of glutathione, and usually this NAPQI will get converted to mercaptopuric acid, which is non-toxic. But in patients who have presented with high amounts of paracetamol with high levels of acetaminophen, usually these pathways will get saturated, the conjugation pathways, and even this pathway of glutathione will get saturated. So at that time, the NAPQI becomes toxic and starts producing necrosis. It starts producing necrosis in what way? In those areas where there is glutathione which is present, and now which is the glutathione where it is depleted. So basically, it is a centrilobular necrosis of the liver which it produces. The classic findings of acetaminophen or paracetamol toxicity. What are the other factors I mentioned? Risk factors which can produce worsening toxicity of paracetamol. I told you fasting. Fasting causes depletion of this GSH transferase and glutathione. Alcohol causes depletion of GSH transferase and glutathione. So there is reduced mercaptopuric and non-toxic metabolites and more accumulation of NAPQI. Similarly, INH, alcohol, fasting, phenytoin, these all can utilize this CYP450 enzyme pathway or the P450 enzyme. 2E1 is the main, and then not utilize that to production of this NAPQI. So these are the various methods by which acetaminophen can produce toxicity, and the risk factors, how they can lead to acetaminophen toxicity or contribute to acetaminophen toxicity. So if you see here, what is the role of NAC? This is the only thing in acute liver failure, only drug which has shown some amount of benefit, and we might as well utilize that. And usually it is in the paracetamol poisoning that we have seen. Also, there are some studies which say that NAC can be utilized in other causes of acute liver failure as well. So if you see, early administration is extremely important. Within 8 hours, this reduces the hepatotoxicity. And usually they have told early, but recent studies have told that time after which this becomes no longer effective, this NAC, This is very controversial. Some studies say up to 24 to 36 hours. Some studies also say that no, it is only 8 hours. So as far as possible, as soon as patient presents to you, you can start NAC administration in case of paracetamol AF as well as in non-paracetamol related ALF as well. So what about adverse reactions? NAC also has got certain amount of adverse reactions. It causes rash, it can cause some amount of angioedema, and it can lead to shock. So you need to be careful while giving NAC as well. It is not without its own side effects. So what is the dosing of NAC and cysteine? If you see, it comes as Accumist as IV. So it is usually 150 mg per kg in 5% dextrose, 250 cc over 15 minutes. That is the first dose. Then you proceed towards 50 mg per kg in 5% dextrose, 500 ml over 4 hours. And gradually you proceed towards 100 mg per kg in 5% dextrose in 1 liter over 16 hours. So gradually 150, 50, and then 100. So this is the way you give your NAC dosing. So what are the other organ-specific complications of acute liver failure? So is it only related to the liver? No. It causes multiple multi-system problems. Basically, it is an acute inflammatory process. So when this acute liver failure happens, the first and foremost thing that you're worried about is the patient developing cerebral edema, neurological problems in terms of cerebral edema, in terms of intracranial hypertension and brain death. So as soon as possible, you start giving your anti-edema measures in terms of your 3% NS or mannitol. Then other things which happen in acute liver failure, coagulation, we mentioned that this is one of the hallmark features of acute liver failure. There is unbalanced hemostasis. There might be thrombocytopenia. There might be bleeding. What about infection? Liver produces a lot of proteins which help us fight infections. So infections start coming up. Bacterial, fungal, pneumopathy. Extremely, you have to be careful while managing these patients. Always do hand rub and manage these patients of acute liver failure. What about hemodynamics? These patients go into a state of vasoplegic shock, and they can also produce a lot of arrhythmia. Hyperkinetic syndrome is basically a sort of yesterday I talked about a hyperdynamic circulation in early phase of septic shock. So they can go towards this sort of situation as well. What about pulmonary? A lot of patients can go towards ARDS. In terms of resuscitation patients, we sort of overdo, and we give a lot of, sometimes we give blood and blood products because of the rearrangements of coagulation, and these patients can go into pulmonary overload as well. What about metabolic? These are the classic features of acute liver failure: hypoglycemia, hyponatremia, hypokalemia, hypophosphatemia, all of this. So you have to give all these replacements, especially hypoglycemia, very high risk of hypoglycemia. You have to continue 25% dextrose infusions and keep monitoring, very frequent sugar monitoring. What about renal? They can produce AKI as well, and patients may go and need further dialysis as well in the future. So these are all the organ-specific complications that you have to deal with in a patient with acute liver failure. And remember, acute liver failure is a medical emergency. It is not something that you can sit on. It is not something where a chronic liver disease patient is presented to you. It is a medical emergency. And why is that? I will come to it later. So what about diagnosis? I told you jaundice, encephalopathy, coagulopathy. These are the hallmark features. But in the organ-specific complications, patients can also present with that as well. So you have to catch that and then go back to your history and catch the acute liver failure. Deranged liver function tests on the labs. When you get your labs, you will have increased AST, ALT, alkaline phosphatase, GGT, as well as bilirubin. All the components of the liver function test, you will have derangements. What about coagulation tests? You will have prolonged PTINRs. What about hypoglycemia? It can cause a lot of hypoglycemia, increased lactates. What about CT brain? Usually we do a CT brain because patients have neurological complications, but usually they are normal in the initial phases until about very late where they can develop cerebral edema. So you have to be careful that the initial CT brain might be normal. So most important, as I said, there is no drug except NAC. But what there is with us is a lot of nursing considerations that we have to consider when we manage acute liver failure and let the liver recover on its own by giving supportive care. So what nursing considerations? Encephalopathy. Continuously, we have to assess the GCS. And if the patient is proceeding and worsening, you might have to intubate the patient. You have to check whether if the patient is not intubated, oral intake and mobility is allowed or not. You have to elevate the head end of the bed by 30 degrees. These are the basic things. What about reduced liver function? You have to be careful with your medications. There might be increased half-life of medications, then you have reduced liver function. Where is a high risk of infection? You have to maintain very strict aseptic precautions. Renal failure, input and output monitoring, extremely important. Chances of fluid overload are also there. On one hand, you have renal failure, on the other hand, you resuscitate too much, then it will be pulmonary edema. What about skin care? Patients with acute liver failure, when they have jaundice, they can present with itching. They can have lots of skin lesions which might be there. Those might become the sites of infection. You have to be extremely careful and see the backside of patients as well. What about hypoglycemia? Regular sugar monitoring essential. And of course, last and not the least, is extremely important as intensivists that if your facility has an option of liver transplant, then well and good, involve the liver transplant team quickly. If it does not have, always offer the family a chance to proceed towards liver transplant. That is extremely important. You sometimes cannot manage medically an acute liver failure. You have to proceed towards liver transplant. And so what are the indications and the prediction of a liver transplant in acute liver failure? If you see here, classically, the King's College criteria has been used. You always have to keep this in your mobile, see it at the bedside. If your patients are sort of falling into such criteria, activate this referral to a center where you have a liver transplant. Do not sit on it. Liver transplant might save a patient's life. So if you see here, acetaminophen induced disease, if it is there, the etiology, then if the criteria for liver transplant is fitted here, you see an arterial pH of less than 7.3, or all three of the following, that is the PT more than 100, creatinine more than 3.4, grade 3 or 4, hepatic encephalopathy, then proceed towards liver transplant. This is one of the criteria. Involve the liver transplant team very quickly. What about non-acetaminophen induced disease? So these are the criteria in non-acetaminophen induced disease. And if you see here, non-A, non-B, that is the non-A, non-B viruses, now hepatotrophic viruses, that is hepatitis A and B. If it is non-A or non-B hepatitis viruses, then these are actually one of the criteria for proceeding towards liver transplant, included in the criteria for liver transplant. So these are the various things you have to keep in mind when you are treating a patient with acute liver failure. Go for emergency liver transplant if it is indicated. We proceeded further investigations were done, and finally we also got something called as a model for end-stage liver disease, or the MELD score, MELD, MELD score. So this has also been found to be extremely useful in referral for liver transplants. If you see here, this is a combination of three investigations. One is serum bilirubin, the other is INR, and the third one is creatinine. If you have three values, you can have a score, and based on that score, the mortality can be predicted and prioritization for liver transplantation can be done. This year, if you have a score of 40 or more, there is 100% mortality. This will also help you in counseling your patient's family. If you calculate a MELD score, you can have a score and a percentage mortality for that patient. Accordingly, you can give a number to the family. Let's suppose your score has come up to 25, so it has a 75% mortality. You can tell them scientifically that this is the amount of mortality that we are predicting. There's a high risk of mortality for your patient's relative. So this is all what you can do with your scoring systems and prognosis and a referral for transplants. So to conclude, acute liver failure is a life-threatening emergency. Never take it as a patient who is in chronic liver disease. This is acute liver failure. So it is different from chronic liver disease. Early identification and treatment is essential. And supportive care is cornerstone of treatment. And if you see here, there is no specific treatment except for NAC, which you can give. And everything else is supportive. And this is all done by your nursing staff at bedside. So teach them how to manage patients with acute liver failure. That's the best thing you can do as an intensivist. And an early referral to a transplant center, just in case they satisfy the King's College criteria and the MELD scores are good enough for liver transplant, and involve the liver transplant team quickly. Thank you all for your patient listening.
That's a very good presentation, sir.
Thank you, Chandramali.
So is there any role of liver assist devices here, sir, in acute liver failure?
So acute liver failure, yes, you can do liver assist devices, but very less literature is available on this. The thing is, by the time you send to liver capable centers where transplant is there, patients would have usually got very ill. But yes, liver assist devices can be used as a bridge towards
Bridge,
this
yes.
transplant between
Exactly.
when your patient presents versus when your patient is being sent for transplant. Then definitely transplant has to be done. Liver assist devices have their own problems. They can have a lot of problems, just like the dialysis machine has got so many problems, or the ECMO machine has got problems. Liver assist devices have their own problems. So that is definitely a bridge which you can keep between patient having acute liver failure and patient going for a liver transplant. But definitely it is not a what do you call end destination therapy. It is basically a bridge therapy.
Thank you, sir. Without any delay, I want to welcome Sanjeev Dar, sir, Assistant Professor in Department of Critical Care Medicine, IMS in some hospital, as the next speaker. Sir, Dar, sir, please share your PPT. I think there is a technical glitch. Dar, sir will be sharing the PPT in 2 to 3 minutes.
You have disabled
Just a minute, sir. We will be making a co-host just a minute.
you have disabled the sharing, Chandramouli.
Yeah, sir, give us a couple of minutes. We'll be doing it. Couple
Okay,
of
okay.
minutes. Sanjeev, sir, I think you can share your PPT now, sir.
Okay.
Please share your PPT.
Sanjeev, this audio is not, it is getting a lot of breaks.
Sir, your audio is not very clear, sir, Sanjeev, sir. I think you have to check your connectivity, I think.
Is it audible now? Now audible?
Is it audible, sir? Audible, sir, audible. Please proceed,
Audible
sir.
now? Okay.
Yeah, sir, please proceed.
Okay. Is it visible now?
Yeah, it's visible, sir.
So good afternoon. This is your first topic of today, acute decompensation of chronic liver disease. So what is acute decompensation of chronic liver disease? So patient with having chronic liver disease, any decompensation in the organ, any organ system dysfunction is defined as the decompensation or acute decompensation of a chronic liver disease. So any organ dysfunction means a patient can have encephalopathy, coagulopathy, or having any bleeding disorder or any AKI or renal dysfunction. So instead, liver disease is the final decompensation phase of patients having the chronic liver disease. So chronic liver disease, this is the fifth leading cause of death globally, we'll see. And simultaneously, this may have a associated multi-organ failure also. And the chronic liver disease patient, then substantial number of patients need the ICU admission, and the in-hospital mortality accounts about more than 50%. And most of the cause of admission are because of these patients have patients present with many complications. So we'll discuss. After discuss the definition part, we'll see what are the causes of ACLD, and then what are the complication and its management. So we'll go through the neurological complication and management, hematological or anybody complication management, and cardiological complication, and gastrointestinal complication, adrenal complication and management, and in last the nutrition. So if you will see the European Association of Study of Liver Disease, they in the latest publication 2023, they have mentioned almost any organ system can be affected in a patient with having the chronic liver disease as acute decompensation. So, what are the causes of advanced chronic liver disease? This most common causes chronic hepatitis, hepatitis C or hepatitis B, or patients having chronic alcohol intake and non-alcoholic steatohepatitis. Other less common causes are Wilson's disease, primary sclerosing cholangitis, or primary biliary cirrhosis, and alpha-1 antitrypsin deficiency for patients having autoimmune diseases, and hereditary hemochromatosis. And there are many genetic causes that are rare causes. And all these subsequently lead to cirrhosis over time. So, what are the clinical implications? Initially, patient have cirrhosis. Initially, have a compensated phase. Subsequently, they progress to decompensated phase. Those are the patient can present with like esophageal varices, ascites, or hepatic encephalopathy, and this precipitating factor can be if a patient having any infection, or a patient having dehydration, constipation, or having any acute bleeding episode or infection. This can lead to from the compensation to go into the decompensated phase. So I have discussed also what are the major complications in liver disease. This can be hepatic encephalopathy, hepatopulmonary syndrome, portopulmonary hypertension, or hydrothorax, varices, hepatorenal syndrome, and spontaneous bacterial peritonitis. So what are the indications for ICU admission? These are again indications are if patient need for organ support like vasopressor, mechanical ventilation, or renal replacement therapy, or patient having massive bleeding, or patient having grade 3 or grade 4 hepatic encephalopathy, or patient having a septic shock. And what are the contraindications to the ICU admission? These are all the ESL 2023 guidelines. This patient having a comorbidity associated with a very poor prognosis, or patient having physiological or without biological elderly patient, and a severe pulmonary diseases like gold criteria 3 for COPD, or in cardiac poor cardiological status, or neurological disease of grade 3, or a patient having advanced neoplasm, or a severe to the severe sarcopenia. And if patient has to admitted, it should be admitted either within 6 hours after the diagnosis. So coming first to the neurological complications management,
Sanjeev sir. Sanjeev sir, can you hear me, sir? I think there is some issue with the connectivity.
This is a audible now, Oli?
Yes, sir. Now it's audible, sir. Now it's audible.
So, these are in patient with hepatic encephalopathy. There are many challenges for the diagnosis. What are the differential diagnoses in patients with hepatic encephalopathy? This can be meningitis or encephalitis, or patient having uremia, or sepsis into encephalopathy, or patient having any psychoactive medications, or medication withdrawal or alcohol withdrawal, or patient having encephalopathy. They are the differential diagnosis in patient having altered sensory in chronic liver disease. So another the most common cause is the hepatic encephalopathy. So this is a definition is this is a spectrum of neuropsychiatric abnormality in patient with liver disease in absence of brain disease. So this hepatic encephalopathy does develop in almost 50% cases of cirrhotic patients, and this and associated mortality is about 50% at 1 year. So, what are the clinical events precipitating hepatic encephalopathy in patient with cirrhosis? These are if there is a gastrointestinal hemorrhage or infection, sepsis, or patient having a dehydration, imbalance to electrolyte imbalance or acid-base imbalance, or patient having a renal failure, drug toxins, or other medication intake, or illicit substance abuse, or alcohol, or dietary indiscretion. So, how to diagnose a patient with hepatic encephalopathy? So, the adjunctive neuro test is have a limited role, so we don't have to do a CT or any liver function study. We should do a non-local we should do a neurological examination, and we should see whether there is any clear precipitant events that leads to hepatic encephalopathy, and we should evaluate for the level of ammonia in the arterial blood. So if this we find, then we diagnose this patient having hepatic encephalopathy. There is a limited role of imaging or lumbar function, as I said. So diagnosed by serum ammonia level, the serum ammonia level we use for the diagnosis if in hepatic encephalopathy. But useful, this ammonia is useful, but is not definite for the diagnosis. There is some correlation with the severity of hepatic encephalopathy, but the predictive this is a predictive value for the grade of hepatic encephalopathy. But we should not do a repeated test for ammonia level to see the severity or a trend, subsequent recovery of the patient or subsequent severity of the patient. So treatment of encephalopathy in CID patients. First, we should identify the cause of identification of encephalopathy. So we should know that this patient having a hepatic encephalopathy. Subsequently, treatment of the precipitating factor in parallel with the intensive care support or other supportive management. And the first type of treatment are the reduction in the ammonia level production and also its absorption in the intestine, and nutritional and other micronutrient supplements. There are other secondary treatment, but this is a limited role. So, for the reduction of level of ammonia in intestine, most commonly use the lactulose and the enema. So, lactulose this is the first line of therapy, and but there is no proven mortality benefit. But but decrease the ammonia level in the gut, subsequently decrease the ammonia level in blood, so there may decrease glutamine level in the CCNS. So glutamine that converted from the ammonia that have a main neurotransmitter that have a pathological role in hepatic encephalopathy. So this glutamine can lead to encephalopathy or this cerebral edema and raised ICP also. So by using the lactose, we decrease the ammonia load inside the intestine by decreasing the transit time inside the intestine. So our target should be to have a 3 to 4 loose stool per day. And enema we also use like loose enema or proteolytic enema to increase the or having 3 to 4 loose per day. So these are some of the non-observable antibiotics that we use, rifaximin. These are approved, FDA approved, and also neomycin that is the FDA approved. What metronidazole not this is not FDA approved. Approved. So rifaximin and neomycin, these are non-observable antibiotics that kill the some pathological bacteria that produce the ammonia and decrease the ammonia load. Lola again earlier illustrated that use the urea cycle pathway to convert ammonia to urea, and so thereby decreases the ammonia load inside the arterial blood. But there is again this is a controversial whether to keep L-ornithine elastopatric for patient with CCD. There is no sufficient evidence to prove it. Again, from Ajane, there is no significant, there is no definitive study to suggest the use of formaldehyde in CID patients. Other is the liver transplantation is the definitive treatment for the hepatic encephalopathy, but that is we use it very less often. So second is the coagulopathy as a decompensation. So liver patient, they liver produces many all the coagulation factors except the factor 7 and factor 13, and also the produce anticoagulation, anticoagulant C and S and antithrombin. Sometimes increase in liver disease patient, they have increased factor 7 and one factor and patient, because these are having patient lots of take alcohol at lots of time, so this patient may present with vitamin K deficiency. So the patient may present with a coagulopathy. Simultaneously, there is unpredictable dysregulation of both pro and anticoagulant. So there is a imbalance in the homeostasis. So this patient can present with it as a coagulant episode or sometimes with increased thrombosis also. Again, platelet, there is a quantitative and qualitative dysfunction of the platelet, and sometimes liver disease associated splenomegaly that increase the platelet degradation. Also, sometimes we use the antiviral for hepatitis or hepatitis C that again leads to increased destruction of the platelets. So these patients have a as a coagulation disorder patient present with 30 to 25 to 30% present with a varicose bleed, and 20% patient present with a non-varicose bleed. So also while we do process some procedure, the patient may present have an increased risk of bleeding. Other contributing factors to the bleeding are the infection, uremia, or portal hypertension, or use of thermotropics or other medications. Thrombosis also can be present. As I said, incidence is of DVT and pulmonary embolism is 0.5 to 8%, but alveolar thrombosis present with 8 to 25% in decompensated patients. So thromboprophylaxis, this is again controversial, and sequential comparative to be ineffective as patients may have generalized edema or anesthesia. But prophylactic, this is already says the prophylactic anticoagulation for venous thromboembolism in hospitalized cirrhosis patient is not associated high risk of gastrointestinal bleeding. So do not give any platelet if the platelet count is more than 50,000, or a patient is don't give any prophylactic transfusion type of FAP or any other blood product. There is no role of prophylactic transfusion. So patient is have a bleeding, then you can give transfusions. So management of bleeding, we can use vitamin K blood product transfusion according to the take or rotative assay. Cryopretus should be given over the FFP, and fibrinogen should be transfused if level is less than 120 milligram per deciliter. And protein concentrated complex is patient having severe bleeding, and tranexamic acid or epsilon aminocapric acid may be given in patient active bleeding. These are some of the blood product we can give. The target hemoglobin should be less than, or trigger should be hemoglobin of level less than 7, or platelet 50,000. And if we do any intervention, platelet target should be more than 1 lakh. And obviously, we should do a take guided transfusion. And the severe complication, lactate insufficiency, these are the marker of poor and worsening organ function, and also hypoperfusion. Even in the absence of hypertension, lactate indicates a marker in as a poor prognosis in cirrhosis patient. So there is no particular guideline when to how frequently we should check for the lactate. LD lactate clearance is an indicator of improved outcome. Ascites again another complication factor, gastrointestinal complication or decompensation. So this is the most common complication in patient having intestinal liver disease, and when ascites is present, that increases the mortality. So 1 year the survival is 85%, but 5-year survival is only 56%. And causes of ascites, these are because of portal hypertension, and sometimes malignancy or heart failure or infection can be also present. So if ascites is present, we do a parasitosis to evaluate the ascites, and we see the serum ascites albumin gradient. If less than 1.1, that indicates a portal hypertension induced by cirrhosis or congestive heart failure or portal syndrome. If SAG is more than 1.1, this can be TB pancreatitis or other causes. Other management of ascites are dietary sodium restriction and diuretics, pyrolactin or furosemide can be used. And a patient have sometimes hepatitis ascites or large, in this case we do a large volume of parasitics or LPP. So according to guideline, ESA guideline, if we are doing ascites of less than 5 liter, in those cases, uncompleted ascites, we don't need to any albumin. But if we are doing large volume parasitics more than 5 liter, then we should transfuse albumin. That is 8 gram of albumin should be given for every 1 liter of ascites removed. So that would be approximately around 100 ml or 20% albumin for every 3 liter of ascites removed. So another is the gastrointestinal bleeding. Most common is the varicose bleeding. So varicose bleeding, normal your particular gradient has the 3 to 5 millimeter of 3 to 5 millimeter of mercury is normal. When there is more than that is more than at the that presented the varicose hemorrhage. Non-viral cell bleeding causes photohypertensive gastropathy or gastric or duodenal ulcer or arteriovenous malformation. So management, again, the basic management airway breathing circulation in resuscitation with heavy hemoglobin is less than 7. So vasoactive agent in mostly for varicose bleeding due to varices, gastrosporoviruses, we keep the telepresence is the most commonly used. Otherwise, the octreotide for somatostatin analogs. Certainly, I'm not going about the in detail of the telepresence, but we usually use a 1 milligram QID dose. So antibiotic patient presenting with very celebrated antibiotic should be given for every patient because this patient present with immunocompromised state and may simultaneously may subsequently present with sepsis or septic shock. And patient with varicose bleeding endoscopy after stabilization and therapeutic endoscopy should be done within 24 hours of the admission. And endoscopic varicose lecture should be prepared for the sclerotherapy. And combination therapy sometimes improve the outcomes. And if it doesn't stop, rescue therapy should be given that these are tips transjugular intravenous photo system shot, or before that we can go for a balloon tamponade, but balloon tamponade is a temporary mode of management. Last, another is the renal decompensation that present as a hepatorenal syndrome. So hepatorenal syndrome this occurs because of massive renal vasoconstriction in the setting of the systemic or blunting arterial vasodilation. So when in intestinal liver disease, patient usually present a vasodilatory stress of the blunting vessel or systemic vessels. So diverting the blood from the kidney, or sometimes present having a renal vasoconstriction that leads to AKI. So I have to diagnose, this is second ESL guideline criteria for the diagnosis of HRS. So patients should have a diagnosed case of a cirrhosis and ascites and a diagnosis of AKI according to International Club of Ascites AKI criteria, and no response after 2 consecutive days of a diuretic withdrawal and a plasma pool expansion with albumin 1 gram per kg body weight, and there should be absence of shock, no current or recent use of any nephrotoxic drugs like NSAID, aminoglycoside, or any contrast media, and any absence of any structural kidney disease. That is absence of proteinuria more than 500 milligram per day, or absence of any hematuria or more than 50 RBC per high parfit, or normal findings of renal ultrasonography. So USG should be normal also. So management of HRS, we shall keep 20% albumin in these patients, and albumin dose is 1 gram per kg per day for 2 days with maximum 100 gram per day, followed by 20 to 40 gram per day. This should be combined with a telepresence 1 milligram per kg, 1 milligram QID for 4 times a day. So other management for HRS are the tips and or temporary management are the cortisone replacement therapy. And the last is the nutritional supplement in endoscopic hepatitis patient. This patient is present with a protein calorie malnutrition, and 70% patients present with moderate degree of malnutrition, but 38% of or larger patients also present with severe type of malnutrition. And this malnutrition increase with advanced stage. And a patient with present with malnutrition, that again increase the risk of complication. So if you present patient with malnutrition, this can have even increase the length of ICU stay and hospital stay. There is also to increase risk of mortality. So nutritional goal are usually 20 to 35 kilocalorie per kg per day. The energy should be given, and in patient with hepatic encephalopathy, we should not restrict the protein diet for the patient. But ISBN recommend the branched amino acid should be used in patient with hepatic encephalopathy. And whole protein supplements are preferred, and there should not be any particular protein restriction. So prognosis, there are many prognosis scoring systems are available. The SOFA score, CLIP SOFA score, Apache 2 score, and a BED score. And strongly, so the strong association with higher in ICU mortality. So thank you. This was my presentation about acute versus chronic liver disease. Molly, is it audible?
Thank you, Dr. Sanjeev.
Yeah,
The next
Sanjeev sir,
presentation is okay.
Sanjeev sir, thank you for excellent presentation.
Thank you.
Without any delay, I want to welcome Dr. Sachi Chaudhary to speak on abdominal compartment syndrome next. He is working as assistant professor in IMS and some hospital, Department of Critical Care Medicine. Sachi sir, please share your slides. After you, sir.
Is it visible?
Yes, sir. Your slides are visible and your voice is audible. Please proceed, sir.
Yeah. Good evening, everyone. So the next topic we are going to discuss is abdomen compartment syndrome. First, coming to the definitions, intra-abdominal pressure is defined as the pressure within the abdominal cavity, and the normal value is 5 to 7 millimeter mercury. Most of the critical ill patients. And intra-abdominal hypertension is defined as when the intra-abdominal pressure is more than 12 millimeter mercury, causing occult ischemia, but without any organ involvement. Then what is abdomen compartment syndrome? It is IAH with at least one overt organ failure. And abdominal perfusion pressure is calculated as the difference between mean arterial pressure and intra-abdominal pressure. So elevated intra-abdominal pressure reduces blood flow to the abdominal viscera. Abdominal perfusion pressure is considered to be better than other resuscitation endpoints like hourly urine output for predicting the outcomes. A target abdominal perfusion pressure of at least 60 milliliter mercury is correlated with improved survival from acute abdomen compartment syndrome. So this is a schematic diagram showing how the increase in intra-abdominal pressure leads to organ involvement leading to abdomen compartment syndrome. When the IAP is more than 12 millimeter mercury, we say it's intra-abdominal hypertension, and when it exceeds more than 20 milliliter mercury with decreased organ perfusion, that leads to abdomen compartment syndrome. Now, what is primary issues when there is some intra-abdominal issue due to presence of some like say pancreatitis or something, or there is some retroperitoneal pathology that we call is primary issues, and sometimes damage control laparotomies for trauma or large retroperitoneal hematoma also lead to abdominal compartment syndrome. And secondary issues due to generalized capillary leakage with massive fluid resuscitation, say in case of septic shock resuscitation, that leads to edema of the otherwise normal bowel, leading to the development of tense ascites. Also, in burn injury, hemorrhagic shock, it gives rise to secondary abdominal compartment syndrome. And in some rare cases, primary ACS is followed by secondary ACS. And what is recurrent ACS? When ACS develops after treatment for either primary or secondary ACS, that is called as recurrent abdomen compartment syndrome. Now this gradation, we have graded it into 4 types: grade 1, 2, 3, 4. Grade 1 when IAP is less than 12 millimeter mercury, normal less than 12. Grade 1 when it is between 12 to 15 milliliter mercury is called grade 1 ICH or IH. Grade 2 when the IAP is between 16 to 20 milliliter mercury. Here there is very less likely that organ dysfunction occurs. In grade 3 when IAP is between 21 to 25 millimeter mercury, and it is here also organ dysfunction is less likely, but when the IFE reaches beyond 25 millimeter mercury, that is grade 4, here most of the time there occurs overt organ dysfunction, and it's called ACS. Now, this is the incidence of IH and ACS following some major events that we commonly deal. Following major abdominal surgery, SCS percentage is around 33 to 41%. And following liver transplant also, SCS occurs in about 31% of cases. In major trauma, IH incidences are around 50%. In ICU patients, for various diseases, we encounter IH in about 30 to 54% of the cases. In septic shock, also IH and SS percentages are quite high. And in severe acute pancreatitis, IH sometimes reaches up to 80%. Further classification, it has been done hyperacute, acute, subacute, and chronic IH. Hyperacute, when elevation of intraabdominal pressure lasting only for a few seconds, like laughing, coughing, straining, sneezing, or defecation, or some physical activity. Acute IH, when elevation of IIP that lasts for hours. It usually results of trauma or intraabdominal hemorrhage, and also it can lead to the rapid development of abdominal compartment syndrome. And subacute IH, when elevation of IH that develops over days. It is most common in medical patients and also can lead to abdominal compartment syndrome. Then what is chronic IH? When elevation of IIP that develops over months, say pregnancy or years, like in morbid obese patient. It usually doesn't cause ACS, but does place the individual at high risk for developing ACS if there is some superimposed acute events. And coming to pathophysiology, when intraabdominal pressure becomes more than 20 millimeter mercury, there occurs decreased perfusion of capillary beds. That in turn leads to tissue ischemia and activation of inflammatory mediators. And capillary leak produces more tissue fluid influx, so leading to a further increase in intra-abdominal volume and pressure, and perpetuating this cycle. Another factor is the impairment of lymphatic outflow and subsequent increase in intestinal edema. That can be depicted in this flowchart. Following the physiological insult, there occurs ischemia and release of inflammatory mediators, causing capillary leakage. Then fluid resuscitation is done. That in turn gives rise to tissue edema and bulbar and mesentery edema. So that ultimately gives rise to intra-abdominal hypertension and abdominal compartment syndrome. What are the risk factors associated with development of ACS? First is diminished abdominal compliance following abdominal surgery, a major trauma, born or prone patient. Increased intraluminal contents like ileus, gastroparesis, colonic pseudo obstruction, valvulus. Similarly, increased intraabdominal contents like in case of pancreatitis, distended pancreas, distended abdomen, hemoperitoneum, pneumoperitoneum, or intraperitoneal fluid collection, intraabdominal infection or abscess, intraabdominal or retroperitoneal tumors, lab with excessive insufflation pressure, liver dysfunction, cirrhosis, ascites, peritoneal dialysis. Similarly, capillary leak or fluid resuscitation, damage control laparotomy, hypothermia, polytransfusion, and other causes like bacteremia, coagulopathy, massive incisional hernia repair, mechanical ventilation with high positive pressure ventilation, high PEEP, peritonitis, pneumonia, sepsis. All these things will lead to intra-abdominal hypertension and subsequent development of abdominal compartment syndrome. Now, what are the physiological effect of this intra-abdominal hypertension and ACS on various organ system? First, neurologic function. Increase in intra-abdominal pressure leads to increase in intracranial pressure, which in turn leads to decrease in cerebral perfusion pressure, causing altermentation and further subsequent damages. In pulmonary function, it increases pulmonary vascular resistance, increases edema, inflammation, increases dead space ventilation and shunting, and decreases lung compliance and all lung volumes, which in turn leads to hyperventilation, hypoxia, hypercapnia. Similarly, in cardiovascular function, it increases mean arterial pressure, increases sustained vascular resistance, increase afterload, decrease preload, or decrease because of decrease of venous return, decrease in ventricular compliance. Because of increased IFP, there occurs compression in the heart, so ventricle cannot contract properly. Then decrease in cardiac output, increase heart rate, contractility, and there is increased risk of thrombosis. In GI system, there occurs splanchnic hypoperfusion leading to decreased mucosal pH, intestinal edema, bacterial translocation, and there occurs increased intestinal permeability. Similarly, in hepatic function, there occurs decreased hepatic flow, decreased portal blood flow, decreased cytochrome function, decreased glucose metabolism, and decreased lactate clearance, leading to hyperlactinemia. In renal function, there occurs decreased renal perfusion and renal blood flow and decrease in GFR, so ultimately leading to oliguria and anuria. And there occurs increased tubular toxicity because of increased angiotensin 2 and increased ADH hormone release. In integumentary function, there occurs decreased abdominal wall compliance, decreased rectocyte perfusion, and increase in edema and inflammation, and increased wound complications. Now, what are the signs? So, because of involvement of all these organs, obviously patient presents with the following signs and symptoms. There occurs systolic hypertension, narrow pulse pressure, lactic acidosis, tachycardia, abnormal mentation, acute kidney injury, acute respiratory failure, hypoxia, hypercarbia, increased peak pressure, peak airway pressure, decrease in tidal volume, and acute hepatic failure. Now coming to the diagnosis. Clinically, the measuring the abdominal girth cannot be used as a reliable marker because it very poorly correlates with intra-abdominal pressure monitoring. So clinical IAP estimation is very far from accurate measurement through abdominal girth monitoring. Similarly, radiological investigation, plain X-ray abdomen of chest X-ray, abdominal ultrasound, or CT scan, they are very insensitive and they cannot give us very pretty much idea about the development of SCS. So how to measure the intra-abdominal pressure properly? So bladder pressure monitoring through Foley's catheter, it is currently considered as the standard for monitoring abdominal pressure. It is comparable to direct intraperitoneal pressure measurement, and good thing is non-invasive, and it is more reliable and reproducible than clinical judgment. The reference standard for intermittent IAP measurement is by the bladder with a maximal installation volume of 25 ml of normal saline. And IAP should be expressed in millimeter of mercury and measured at the end of expiration in the supine position after ensuring that abdominal muscle contractions are absent. And for that, if required, we can use neuromuscular blocking agents. And the transducer should be zero at the level of mid-axillary line. For this, first we need a three-way Foley's catheter, one for irrigation port for continuous infusion, one for balloon inflation port, and other is urine drainage port. This is the entire setup how we are going to measure the intra-abdominal pressure using the Foley's catheter by the intravesical pressure. These are the things we need. One is transducer, two stopcocks, one 60 ml syringe, one tubing with saline bag, one tubing with lever both ends, one needle clamp for Foley's. So what are the steps? First, after connecting the Foley's catheter, we need to instill 25 ml of sterile saline into the bladder. Then the catheter tubing is clamped and the needle is inserted via the specimen collecting port proximal to the clamp. The needle is connected to the pressure transducer. Any variation in IAP with central abdominal pressure confirms that there is good fidelity of pressure transduction. And here we should remember that it should be measured at end expiration with the patient completely supine. And the abdominal muscle contraction should be absent and the transducer is zero at the level of mid-axillary line. And the value should be expressed in millimeter of mercury. These are the advanced technologies used, but of course we are not using here, but they have got certain advantages like up visor. Once attached, it is left in place during the entire time, and there occurs continuous IIP measurement. It needs only 30 seconds to measure IIP. This is the up visor kit, which is used to measure intraabdominal pressure. It has the advantage that it has got standardized measurement, no reproducibility errors, ease and simplicity of use, and 30 seconds is all that we need to get the data. It's a closed system, and the most important thing is, unlike Follies where there is high risk of contamination, here there is minimal contamination risk. Now coming to the management of abdomen compartment syndrome or IH. First thing, IIP monitoring should have a very low index of suspicion. We should not delay the diagnosis by delaying the measurement. Then we should identify promptly the patients at risk. Then prevention. How to prevent? If you are suspecting that the patient is going to abdominal compartment syndrome, then preferably prophylactic laparostomy can be done, or open abdomen treatment can be performed, and judicious fluid resuscitation should be there. Then, if already patient has developed IS, then medical management should be tried first, well, by various IIP reducing strategies. What are those? That we'll be discussing in the next slide. And then if all the measures medical management fails, then ultimate treatment is surgical management by decompressive laparotomy. So this is the table which discusses about the management. You can see there are various steps. Currently, we'll proceed mainly 5 broad headings we need to take care for control of IH. One is first evacuate intraluminal contents. For that, we need to insert an nasogastric tube or rectal tube if required, and initiate gastro or colo prokinetic agents. If it fails, then we should minimize enteral nutrition. And if required, we can take the help of NMS and consider colonoscopic decompression. Still, it's not helpful, then we should discontinue completely enteral nutrition and start parenteral nutrition. Next step we should look after is evacuate any intraabdominal space occupying lesion. For that, we need to diagnose it first by doing an abdominal ultrasound, or if required CT. Then, but if we find any lesion, we can drain it through percutaneous catheter. Then, if required, take surgical help also. Then, improve abdominal wall compliance by ensuring adequate sedation, analgesia, and if there is any constricted dressing, it should be removed. If there is escharotomy should be performed. And here we should avoid the prone positioning of the patient, and head end should be elevated maximum up to 20 degrees, not more than that. And sometimes we keep the patient in reverse sterile position also. And if required, as we discussed, we can take the help of neuromuscular blocking agents. Then there should be optimized fluid administration. Excessive fluid should be avoided. Better to aim for 0 or even negative fluid balance if the patient tolerates hemodynamically. And resuscitation should be done using hypertonic fluid or colloid if required, so that less fluid can be administered. And diuresis, fluid removal through judicious diuretic use. Here you should remember that diuretics directly no role in reducing intraabdominal pressure. It can only produce diuresis so that negative fluid balance can be achieved and gut edema can be lowered. If all the measures fail, then we can consider hemodialysis or ultrafiltration. Similarly, optimize systemic or regional perfusion by goal-directed fluid resuscitation, and we should try to maintain an abdominal perfusion pressure of at least 60 millimeter of mercury. And hemodynamic monitoring to guide resuscitation should be carried out. And if all these steps, first, second, or third step fails, then the last final step is to go for surgical decompression or abdominal decompression. But this is a general agreement that surgical decompression is indicated for abdominal compartment syndrome treatment. Decompressing the abdomen prior to the development of ACS is becoming increasingly common nowadays. Most surgeons perform decompression and they maintain an open abdomen for a few days using the temporary abdominal wall closure technique. Surgical decompression can be performed in the operating room itself, or if the patient is very critical, sometimes it is carried out bedside in the ICU setup also. While decompressing, we should take care that on decompression there occurs sudden decrease in intraabdominal hypertension. So there occurs decrease in blood pressure and anaerobic metabolism, leading to respiratory alkalosis and release of various byproducts causing arrhythmia. So here we should remember that before going for decompression, we should always, the patient should be adequately preloaded. Now, what are the various temporary closure techniques? In some patients, the delayed primary closure of the abdominal fossa is possible once edema subsides. So, these are the methods like Baker method for a vacuum-assisted temporary abdominal closure. And another method is sponge-based negative pressure wound system. Then, in some cases, surgeons prefer to use Bogota bag for managing an open abdomen for a few days. So conclusion, do not wait for signs of ACS to be present before you decide to check intra-abdominal pressure, because by that time the patient is already gone. You have lost your opportunity for medical therapy. And monitor all high-risk patients early and often train IFP like a vital sign. Intervene early before critical pressure develops. Thank you. Excuse me.
That is a very nice presentation, Dr. Sachit, sir.
Thank you,
So
Maulik.
you have emphasized on the time points as well. So without any delay, we will call Dr. Dr. Viswajit Naik, sir, to present his next topic on toxic megacolon. He is associate professor in Department of Critical Medicine, IMS and some hospital, Bhubaneswar. Sir, Viswajit sir, kindly share your screen after you.
Maulik candidate is enable the
You are enabled.
Yeah, you're right.
Enabled already.
Sir, your voice is not very clear, sir. Kindly check your connectivity, please.
Audible?
Yeah, you're audible, sir.
Maulik?
Yeah, audible.
Yeah, you're audible, sir. Please share your screen.
Now visible?
Yes.
Is it visible?
Yes, sir. Yes, sir. You can see your slides and we can hear your voice as well. Please proceed, sir. Proceed.
Fine. Good evening. Good evening. So now we'll discuss regarding toxic megacolon. So from its name, it's a large size colon with systemic toxicity presently acutely, hence it's called the toxic megacolon. But it's a life-threatening complication, and here the dilatation is usually non-obstructive, and it's through entire length of the colon. It's a pan colony, and it should be more than 6 centimeter, and some says it's more than 5 centimeter also. Now coming to diagnostic criteria, Jalan et al. Where this criteria, which is erect abdomen X-ray showing colonic dilatation plus 3 of the any these 4 findings, like fever more than 38 degree, heart rate is more than 120, neutrophil high neutrophil like more than 10,000, and anemia,
Sir,
and plus one of the hello. So it is audible,
sir.
Molly?
There is some
Audible,
issue
sir?
with your voice actually. Can you check it, sir? check your connectivity.
చాలా
fever,
ఉన్నాయి
heart rate,
Dr. Lokya Pola, please mute yourself. Dr. Lokya Pola.
Please start the presentation. Biswajit sir, you are not audible. Biswajit sir, you are not audible, sir. There is some issue with the connectivity.
what?
Biswajit sir, please share your screen.
Audible now?
Yes. Now you are audible, sir.
Fine. So we are at the diagnostic criteria. So erectus abdomen X-ray showing colonic dilation, flaws. Three of the any these findings like fever more than 38, heart rate is more than 120, high TLCO more than 10.5 thousand, and anemia. And plus 4 like dehydration or maybe ultrasensorial electrolyte disturbance or hypotension. So now diagnosis is clear. Coming to etiology, the main cause of the most common cause is actually ulcerative colitis, and but the infectious cause, the second most cause is the septicemia, and most in the ICU importance is the this is Clostridium difficile infection, but can also be caused by the Salmonella, Shigella, or CMP infection. Coming to ischemic cause, it's like bowel or ischemia, in fact, and most commonly hypokalemia is associated with megalodon. And coming to medication, it's mainly anticholinergic drugs like antidepressants, antimodulatory agents, or opioids, which paralyze the peristalsis. The others like procedure like barium enema, colonoscopy, and valve replacement may cause megalodon. Now coming to differential diagnosis, uh, it's an acute interstitial option which is mechanical, like in Volvo's case, and here's some disease in children, which is aganglionic in the colon, and congenital megacolon, chronic constipation into megacolon, and pseudo obstruction, which is called oblique syndrome, and malignance causing obstruction. Coming to investigation, and for the pillar like clinical, laboratory, radiological, and invasive. Coming to clinical, these patients are usually temperature, looking toxic, and already discussed there is anemia, so there is pallor, and maybe this is due to impending perforation, and maybe there is saw present, so there can be tachycardia and altered mentation. And coming to local examination, there is distension of the abdomen and tenderness is there, and there is also you can find rebound tenderness also. Coming to lab, there is higher TLC with high volume count. There is anemia. There is you can find metabolic alkalosis due to third place loss, and hypokalemia is usually associated with
toxic megacolon. There is high SR and CRP because it is highly inflammatory condition. So there is usually associated with high SR and CRP value. And stool examination for routine and microscopy, and C. diff toxin and glutamine dehydrogenase assay should be done for by enzyme immunoassay. And HIV screening is required because HIV people are more prone to CMV like colitis. So we can go for this any specific viral marker. So as the C. diff is more in the cause of toxic megacolon in ICU, so diagnostic test for C. diff is gold standard is toxicity culture, but it is difficult to perform and time consuming also. Second one is cell cytotoxicity assay to detect the toxin A and B, but it's also difficult to perform, time consuming. But the rapid test are glutamate dehydrogenase by enzyme immunoassay, but it is not specific. But most commonly we use the detection of the toxin A and B through enzyme immunoassay method. It is rapid and but it is most expensive. So the rapid but specific sensitive is NAT and PCR. Then coming to radiology, abdomen X-ray or through CT scan abdomen, there is dilatation of the colon, which is more than 6 centimeter. There is loss of obstruction. It will present in the colon. There is loss of obstruction, so it is more likely linear. And there is segmental colonic wall thickening. You can thinning. This wall may be segmentally thin out. And you can find air fluid level and nodular pseudopolyps. Here you can find the nodular pseudopolyps. It is nothing like the ulcerated mucus lying inside the lumen. Mucosal ulceration can be this ulceration. In the CT scan, we find accordion sign, that is accordion actually a musical instrument. So it is finding like it's a deep mucosal ulceration. These are the which take more of that contrast agent. So there is one is low intensity and high intensity from bands, along with that thickened submucosal fold. So it's called acute sign, and it is specific for the. It is not specific for the C. diff megacolon, but common found. Another is target sign. It is actually this is the target actually. This is the mucosa which takes more interesting agent along with the base underlying some mucosal edema. So it is called target sign. Here it is 1, 2, 3, 4 target signs are there. Fourth one is the colonoscopy or sigmoidoscopy. The complete colonoscopy may be harmful and may cause perforation because as we inflate through while going through the colonoscopy, the air may further inflate the colon, leading to perforation. So limited examination without all preparation is safer. Limited colonoscopy is actually advisable. So we can go through we can go through to descending colon and transverse colon only. Now coming to management, the first we know that is ABC approach. And the patient is usually shocked. So after stabilization and routine investigation, we should go for the radiological examination. That should be done 12 hours apart. So serial abdominal X-rays is a better chance of management, and fluid resuscitation is to be done, and electrolytes have to be corrected, like hypokalemia. Coming to medical management, treating underlying cause is the main primary goal. So coronary decompression first should be done. Rans tube is inserted for decompression. Patient should keep NPO to give the bowel rest. Intra-pressure monitoring may be initiated if there is suspicion of intraabdominal hypertension. And if patient is stable, then we should mobilize the patient. And there may be can be knee elbow position, and patient may be prone 10 to 15 minutes every 3 to 4 hourly, and flash tube can be considered to depressurize colon. Coming to specific condition, like IBD case, hydrocortisone 100 ml 6 to 8 hourly should be administered, and it is not associated with any increased corporation risk. But dexamethasone and methylprednisolone can also be alternative therapy. But patient who has not responded to steroid therapy, we can start infliximab or cyclosporine. However, there is no proven clinical role for these infliximab and cyclosporine. Now coming to CD colitis, this is the most common cause encountered in the ICUs. It is a fulminant colitis. So now the incidence is gradually as there is increasing use of the more antibiotic. So more culprit antibiotics are like mainly clindamycin, cephalosporin, and fluoroquinolones. So culprit antibiotics should be stopped, and alternative antibiotics should be preferred. Vancomycin 500 mg orally every 6 hours, along with IV metronidazole 500 mg TDS is a choice. So if it is not working, then we should go vancomycin retention enema. That is 150 mg of vancomycin enema with 500 ml of NS, and it is to be given per rectal. So patient not responding to this treatment now can go up to injection tigecycline 100 mg followed by 50 mg bit, and we can try with passive immune like IVIG can be tried. So patient has to be carefully monitored for any shift in the hemodynamics and intra-abdominal pressure, as perforation can be a risk, and perforation is associated with very poor prognosis and high mortality rate. Other therapy, medical therapy like leukocytopheresis, colonoscopy decompression with oral vancomycin, hyperbaric oxygen therapy, tacrolimus, and IVIG can be tried. Now coming to surgical management, the medical management fails, then it is better to go up to surgical management without any delay. So the patients having chronic perforation, ischemia, raised intra-abdominal pressure, or patient having abdominal compound syndrome needs surgical decompression. And there is relative indications like when patient having very high leukocyte count with high lactates and who fails to medical therapy can also a relative indication. And the surgical is partial or subtotal colectomy with and ileostomy. But total colectomy and diabetic loop ileostomy can be tried. So coming to summary, patient with toxic macalon has to look for ABC, then start eye fluid, maintain the hydration, correct the electrolytes like potassium, then go for the investigation like biochemical, send blood sample and stool sample for CDF toxic, and radiology. X-ray should be serial X-ray should be done every 12 hours, and NCCT abdomen. And limited colonoscopy or segments can be tried. Accordingly, we can go for conservative management or surgical decompression. Coming to conservative, so patient made kneel for oral diagnostic insertion for patient mobilization if stable, and flatus tube for rectum, knee chest position, and colonoscopic decompression with vancomycin. And if patient still deteriorated, then patient may need ICU or SDO admission for hemodynamic monitoring or IFA monitoring. Then we can go for the specific treatment. So after diagnosis, disease specific, if there is ulcerative colitis, then we should start steroids. And if this is C. diff, then we can go for tab vancomycin and metronidazole. And For CMV colitis, actually, it is not responding very good response to the medical management. So mostly needed surgical decompression. And if it is associated with pregnancy, then high dose steroids should be given. And other therapy like leukocytopharesis, coronary decompression, hypervolemic oxygen can be tried. And again, serial X-ray to level you can do and see the size of the colon. So if the colonic size is same, then we can continue that our treatment and monitoring the IAP and hemodynamic monitoring and TLC monitoring. And if it is findings of abdominal compartment syndrome, or there is shock or high lactate or high TLC, then we can go for the surgical decompression. And the size is increasing, there is chance of perforation, ileus. So again, we go for the surgical decompression. And if the size is further decreases, then patient should be observed with serial X-ray, ABG, and TLC. So then we can start oral feeding and gradually with low volume feed and encourage the mobility. In surgical decompression, as we discussed, subtotal colectomy with endomelectomy is preferred. Thank you. Molly?
Okay, thank you, Dr. Biswajit.
Okay, carry
So
on.
I will be proceeding next session, which is on acute pancreatitis. Thank you, Dr. Biswajit. It was a good class. Okay, so I'll be proceeding with acute pancreatitis. So this will be initially I will start with the case and then proceed towards management of acute pancreatitis. I will not be dealing with each and every specific thing. What I'll be touching on is basically recent updates and bit of management part. That is the main thing we'll be focusing on. So this is a case which I am bringing to you. This is a 71. He's also got of sleep apnea, OSA. He presents to you with emergency department with abdominal pain. So as he presents, he's also got history of IHD, which has resulted in an STEMI requiring management with the PCA stent placement. But this happened 1 month ago, and this patient had to be started on oral clopidogrel therapy because of this STEMI and the which was there with stent placement. So the cholecystectomy planned for this gallstone disease, which this patient has got, was actually postponed. And this patient was sitting with a gallstone disease inside. And the cardiology team had actually recommended to delay this therapy for the gallstone disease. And this clopidogrel has to be continued for a minimum of at least 6 weeks. That is why this gallstone disease had to be postponed. So this is probably a perfect candidate actually for acute pancreatitis. So if you see here on this ABG, there is a bit of respiratory acidosis which is there, which is 59 PCO2, but it is sort of almost compensated, which is here. And this is showing us that this patient has got a bit of OSA, probably due to the OSA that this patient has got. So this is chronic respiratory acidosis indicated by raised bicarbonate and base excess. So if you see here, the ABG is not that much revealing, but when we come to the labs have shown a bit of WBC counts which are high, slight bit of creatinine which is high, and a serum lipase which is extremely high, which is around 6,000. And of course, calcium levels are borderline low. So this is indicative of diagnosis of acute pancreatitis. And why is that? What is the diagnostic criteria? Why am I telling that it is an acute pancreatitis? Basically, if you see 2012 revised Atlanta classification, the diagnosis requires at least 2 out of the 3 things to be present. And amongst them, the first and foremost is there should be a certain amount of abdominal pain, which is consistent with pancreatitis. Patient had abdominal pain. Patient should have serum amylase and or lipase. So remember, any one of them is equally good and at least 3 times the upper limit of normal value. This is for the diagnosis part. And the third thing is findings should be consistent with acute pancreatitis on any imaging which might include a CCT, an ultrasound, or an MRI. So an ultrasound is also good enough to tell you that this is acute pancreatitis. If you see any two out of these three, if it is present, and you can proceed and do a diagnosis of acute pancreatitis. And of course, the severity is either mild, moderately severe, or severe. So, what is the etiology of acute pancreatitis? In this case as well, as you saw, the gallstone disease was the most common cause, and this is around 40 to 50%. Alcohol is around 20%, and in 20% cases, there is an unclear etiology as well. We don't know what is that. And in those 10 to 20% cases, 60% cases can be solved the etiology by an endoscopic ultrasound. So therein lies an important role of endoscopic ultrasound. In today's day and age, this is an easy thing to do. Gastroenterologists are doing it day in and day out, and you can ask for endoscopic ultrasound cases where the etiology is unclear. So this is how an endoscopic ultrasound looks like. This is an image of an endoscopic ultrasound, and you can catch a sludge in the gallbladder, which is there, which might not be evident on an ultrasound very clearly. You can catch it upon endoscopic ultrasound. So what I just want to touch one of the very important etiologies, which is missed several times in cases where you don't find a cause, is a hypertriglyceridemic pancreatitis. So a lot of our patients due to lifestyle, there is a lot of hypertriglyceridemia happening. And usually patients will present to you with hypertriglyceridemic pancreatitis when the triglyceride levels increase more than 1000 milligram per deciliter. And other likely causes you have to exclude before you zone in on hypertriglyceridemia as the cause of pancreatitis. So how does it cause? Triglycerides produce free fatty acids on metabolism, and finally these free fatty acids will create pancreatitis. But triglycerides levels are actually a flawed measure of the severity and the amount of pancreatitis that these triglycerides have caused, because ultimately the free fatty acids are the ones that cause the actual damage. The treatment is usually with plasmapheresis or with insulin. Insulin is easy to start. It is a medical management that you can do. Plasmapheresis requires a further little more of invasive approach in terms of a catheter and the blood going out of the body. And there is an emerging role of heparin as well. Studies are going on whether heparin can also help in hypertriglyceridemia pancreatitis. So how do you predict the severity? There are several scoring systems. These are trademark questions of all examiners as to ask you about the severity prediction in acute pancreatitis. Apache score can be used, Ranson score, bicep score, modified glass score, Imris score, search criteria, and the bicep. This is the bedside index for severity in acute pancreatitis. This is all what can be used for our prediction of severity of acute pancreatitis. So we'll focus on the management of acute pancreatitis. This can be divided into three phases: early, beyond the early phase, and an aftercare. In the early phase of acute pancreatitis, what we are focusing on is primarily on fluid resuscitation. And we all know fluids, and pain management. This is the cornerstone of any treatment of any acute pancreatitis. So what about fluids? We just pump in as much fluids as possible or not? No, we have to be very careful. Pancreatitis can cause ARDS as well, and you can cause iatrogenic pulmonary edema on top of that ARDS if you keep giving fluids. So the American Gastroenterology Association suggests a goal-directed therapy for fluid management, and it doesn't give any recommendation on normal saline or Ringer's lactate. But you have to avoid HAS fluids, that is heteroethyl starch-based fluids. I would suggest giving balanced crystalloids, which can include Ringer's lactate and several other formulations which are coming in today's day and age. Try to avoid normal saline. It can cause normal and ungap metabolic acidosis. But it has to be goal directed. From the initial periods of time when we went very liberal with our fluids in acute pancreatitis, there has been recent evidence that there should be some restriction of fluids in acute pancreatitis as well. So you have to individualize and give goal directed therapy for fluid management. What about pain? There is no particular analgesic therapy which is superior, but definitely you have to keep good pain control for these patients. Pancreatitis is severely painful. It has got a sort of retrosternal pain, which is very classic, and you have to keep it under control. So this is extremely important. Opioids can be helpful. You can have paracetamol. Okay, all of this can be used. What about antibiotics? This is a very misused drug in acute pancreatitis. You must remember that antibiotics to be used only when there is infection which is proven or it has been clinically suspected. As a prophylactic drug, antibiotics are not recommended. Do not give antibiotics for each and every patient of acute pancreatitis. There will be worsened outcomes if you give antibiotics in patients without proven or suspected infections. Probiotics are contraindicated in severe pancreatitis. There is no doubt about it. Nutrition, enteral nutrition is definitely preferred. Timing of nutrition, several times your patients might not tolerate tube feeding because of the pancreatitis. And that's why you can tolerate, you can adjust feeding and give low amount of feeding or insufficient calorie intake. It can be tolerated up to 3 to 5 days. But after that, you have to think of further ways of increasing your intake up to after 5 days. And that is usually with the NG tube or with an NJ tube as well sometimes. So there are all the various methods you can proceed and increase your caloric intake after 5 days in an enteral route. What is the role of ERCP in biliary pancreatitis? Biliary pancreatitis isn't in our patient. We had a gallstone pancreatitis, which has caused a biliary pancreatitis. So what is it? Whether you have to proceed with ERCP as soon as patient comes, we'll look into that. So early ERCP with stone removal is not effective in mild biliary pancreatitis. Remember, it is not effective. So for patients coming with a gallstone and mild biliary pancreatitis, don't do an early ERCP and stone removal. For patients with severe biliary pancreatitis, ERCP with stone removal is extremely controversial. There are several studies which say you go ahead and do an early ERCP with stone removal. Other studies say, no, don't do that. But definitely an EUS guided strategy can be used. That is an endoscopic ultrasound guided strategy. It can be used. It can avoid almost 70% of patients in 70% patients in whom ERCP was planned. It can be used. Okay. And it can get away with not doing any sort of interventions of required that is required in ERCP by just doing an endoscopic ultrasound. What about emergency ERCP? This is one favorite question of examiners. If you see here, you can do an emergency ERCP within 24 hours of diagnosing a biliary pancreatitis. And you can do that only and only you proceed for an emergency ERCP if you have a concomitant cholangitis. So if you have a cholangitis in a patient with acute biliary pancreatitis secondary to a gallstone, you can proceed with an emergency ERCP within 24 hours. That is the only indication of an emergency ERCP. So if you see here, I have shown you one thing. This is an endoscopic ultrasound machine which has been inserted here, EUS scope. And here what I've seen is this is a pseudocyst which has formed in the pancreas. And this is how we this FNA needle which has been used to aspirate the contents of the pseudocyst. And this is how an endoscopic retrograde cholangiopancreatography is done, or an ERCP is done. You insert an endoscope and go in a retrograde manner through your common bile duct and your pancreatic ducts. So what about the beyond the early phase? If you see beyond the early phase, you might have to do some amount of imaging. So in the revised Atlanta classifications of 2012, the morphology for acute pancreatitis, the morphology part has been based on CCT. Several times you might also have to do a CCT to see that whether it is an interstitial acute pancreatitis or whether it is a necrotizing pancreatitis. In the first 3 to 4 days, never ever go for a CCT because it is extremely unreliable. The first 3 to 4 days, what I mean is first 3 to 4 days of illness of acute pancreatitis. It is not 3 to 4 days of presentation to your ICU. It must be if the patient is presented little late to your ICU and it is the day one of your ICU, you can go ahead with your CCT. But if this CCT has to be at least 3 to 4 days after the start of the illness. So this is where you will have after 3 to 4 days, good amount of collections or necrosis which might be visible on a CCT, and your CCT will help you in that. And sometimes you might have patients within 3 to 4 days who present with abdominal catastrophes, severe abdominal complications. That time only you can do it. The CCT can be helpful to see for what abdominal catastrophe you got within the 3 to 4 day window period. That is the only indication. Sometimes patients fail to improve after 5 to 7 days of treatment for pancreatitis, and you do CCT to determine the presence and extent of this pancreatitis, whether there are complications which have come up for this pancreatitis. And what about acute necrotic collections? Sometimes acute necrotic collections, you want to see whether they have resolved or whether they have developed a wall of necrosis. And if they have developed a wall of necrosis, if they are producing certain amount of mechanical obstruction, you can go ahead and do some interventions. So infected necrotizing pancreatitis, this is an important thing. So sometimes acute necrotizing pancreatitis, acute necrotic collections and walled off necrosis, that is ANC and WON. Basically, all this can become infected. Necrotic collections which have become infected. So this happens around 1/3 of patients of necrotizing pancreatitis, and the mortality is around 15% in such patients. And these patients are diagnosed when these infections have come up in the patients with necrotizing pancreatitis. How are they diagnosed? They can be diagnosed by gas configurations, which are seen on imaging. They can be seen if you do a percutaneous FNSC, as I showed you in an endoscopic ultrasound. If you do an FNSC, you can probably get a gram stain or a culture or a percutaneous FNSC from the retroperitoneal area as well. And of course, you can also have suspected clinical diagnosis, patient having persistent new onset fever spikes, which are not remitting. So this is one of the also the diagnosis of acute infected pancreatic collections in necrotizing pancreatitis. So antibiotics, when to start? So when you see such infected necrotizing pancreatitis, then you have to start antibiotics if it is proven or it is highly suspected. So how does it help, these antibiotics? This is another favorite question of examiners. It helps to treat the infection, plus also it helps to support the collection, which is a necrotic collection, until it reaches encapsulation. And once you reach encapsulation, eventually you can drain this encapsulated collection by a catheter drainage or a necrosectomy. I'll come to that a little later. So if you see here, this is some amount of peripancreatic necrosis that I have put up here. This is the dark areas form of necrotizing pancreatitis, which is there on the CT scan. If you see here, there is also infected necrotic collections with gas configuration. So this is the pancreas over here, and there are infected necrotic collections. This is collections and this is gas configurations. This is on day 20 of the onset of disease. But till now, it has not got encapsulated. There's no capsule that is visible till now. If you see here, antibiotics were given and this patient developed a wall of necrosis. Okay, so if you see here, there's a nice wall over here, which is formed, and this wall of necrosis can be easily drained with a percutaneous drainage or a necrosectomy. So what about interventions? Initially, historically, there was an early laparotomy which was done to debride the necrotic tissue. But nowadays, the guidelines say, as I said, you have to delay the intervention until this necrotic collection and reached up to a wall of necrosis situation, where there's a complete wall around the necrosis. And also, this approach has to be in a step-up approach, where you directly don't go for necrosectomy in an open approach. You initially go for a catheter drainage and then you proceed towards necrosectomy. And once the catheter drainage also has not improved the patient, you can proceed towards necrosectomy. Surgical necrosectomy as a last option, it can either be open or closed. Usually, again, this is a closed approach, which usually patients usually is preferred. So this closed approach is also called as a video-assisted retroperitoneal debridement. This is one of the terms you have to remember. They will keep asking you in exams, what is the closed surgical approaches? This is called as the WARD approach or the video-assisted retroperitoneal debridement. So these are the approaches that you know. Endosonography guided transgastric necrosectomy. This is not much into practice. This is the one that is the WARD approach that you have to remember. So how do we do that? A few images on that. The first surgical step up in a video-assisted retroperitoneal debridement. If you see here, this is a cross-sectional cut from a patient. This is a infected necrosis here, over here. And if you see, this is the pancreas, this is infected necrosis, and you put in a catheter over here. So if you see, this is the A image. This is the area of detail where we have put a CT-guided percutaneous drain. This is the drain which has come up. Outside, you will connect it to a bag, and this will keep draining, and the whole necrotic collections will come out. The second B part, if you see, this is a CT-guided percutaneous drain which has been put here. This is the same thing which is shown. But if you see here, this does not resolve the, the necrotic collection that well. And then they proceeded towards doing necrosectomy. Okay. And what they did was they did a WARD procedure, that is a video-assisted retroperitoneal debridement. If you see here, they put in retractors over here. This is a catheter is there in situ. So how it helps is when you go ahead, whatever amount of necrotic collection you remove, initially see you remove it off with forceps under direct vision, and this catheter will help you guide your forceps also towards the right place. This is used as a guidance. If you see here, then the further amount of collections which those also have not got removed from the catheter. So what they did was they cracked the catheter and then proceeded inside with a video scope, and that video scope. So if you see here, there are approaches to the necrosectomy. This we saw was a video assisted approach, where a approach. The other approach was an endoscopic transluminal necrosectomy. So how is it done? So if you see here, these are all endoscopes which are there. This is the black colored endoscope. This is figure B. In A, what you see is endoscopic transluminal drainage. Okay, ETD. And in figure B, you see endoscopic transluminal necrosectomy. Okay, so this is only a drainage with an endoscope, and this is a complete necrosectomy done with endoscope. So if you see, in the endoscope is inserted inside here, then once they penetrate the gastric wall and go through and reach the necrotic collection. And once they reach a necrotic collection, they do a little bit of balloon dilatation here. If you see here, rounded shape is here. So this is a bit of balloon dilatation, and they put two double pigtail stents. So we know in HUN cases, a lot of times pigtail stents are put or double J stents are put. So that sort of stent where they put two pigtail stents and they try to keep this this whole thing patent, that is through the stomach wall and into the necrotic collection. And they try to put even a nasocystic catheter, that is a nasal cyst, that is the cyst inside the pancreas or the necrotic collection inside the pancreas. They put a catheter, and that you can aspirate and keep draining as much as possible. So this is one of the endoscopic approaches. The other endoscopic approach is a necrosectomy, that is you proceed and you do further dilatation of the tract with the endoscope, and then you do a complete necrosectomy of the pancreas. So this is also one of the methods by which you can proceed. So what about aftercare? There are several things that you have to keep in mind in aftercare as well. There are several times patients present with recurrence of acute pancreatitis, around 20% cases with recurrent pancreatitis and around 10% of cases with chronic pancreatitis. Remember, when you have mild biliary pancreatitis, you can do a cholecystectomy in the same hospital admission. But when you have a severe biliary pancreatitis, delay it until patient has recovered, and at least 6 weeks after discharge, you proceed towards doing a cholecystectomy for this patient. So putting it all together, just to summarize what I've taught you till now, this is the early phase of acute pancreatitis from day 1 to day 7. So when you see on day 1 on the initial admission, you do all of this history taking, examination, lab tests, amylase, lipase, calcium, triglycerides, all of this. You do a ultrasound, abdominal ultrasound, you try to do a severity prediction with your scoring systems. So if you see, the initial part is your diagnosis and treatment part. So this, if you see, this is the initial admission. But if your patient has got a biliary pancreatitis with a cholangitis, you proceed towards an early CRCP within 24 hours and try to remove the biliary stone which is there. This is the only indication for proceeding with the early ERCP within 24 hours. Rest all of the cases, you can delay your ERCP. You can only do an endoscopic ultrasound. So if you see here, day 1, 2, 3, 4, 5, all of this time, these blue areas have to be taken care of continuously. What are these blue areas? Fluid resuscitation, pain management. And if the patient is doing good, then you start an oral diet. If there is no adequate intake, you start an enteral support, nutritional support. Definitely no prophylactic antibiotics, and you give maximum supportive care in ICU in case of any organ failure that develops. But by the 5th day, if the patient has not shown any signs of clinical improvement, that is the time point when you start suspecting complications. You have to image the patient further now. That is the CCT. You proceed at least after day 4 to 5. Earlier than that, do not do a CCT unless you really have serious doubts on the diagnosis, or you start having complications within that 5 days, you seriously suspect some complications. Otherwise, you always do it after day 5. What about mild acute biliary pancreatitis? If you see here, patient would have recovered by day 5, 6 in mild acute biliary pancreatitis, and you can do a same admission cholecystectomy by day 6 or 7 in such mild acute biliary pancreatitis. And what about necrosis or peripancreatic collections? If you see here, this is something that we might see on a CCT. So then we proceed to the next slide. If you follow my pointer. If you see in the next slide, then comes, that was the week, day 1 to 7. Now we've got to gone towards the next week. That is week 2, week 3, week 4, week 5, week 6 and beyond. In all or any of these phases, you keep continuing your maximum amount of supportive therapy in ICU if there is any organ failure. But during any of this time, even after 7 days, if there is no clinical improvement, what do? You repeat your CCT scan. And in case of any doubt that there might be a necrotic collection which is infected, then you consider a fine needle aspiration through your endoscopic ultrasound or through a percutaneous approach. So if you find an infected necrosis, is it a walled off necrosis? This is one question you have to ask yourself. If it is no, that is, it is not a walled off necrosis, you continue your treatment with antibiotics and supportive care. Without the walling off, there is no role of any interventional approaches, either by percutaneous or by necrosectomy. If that is walled off, yes, the necrosis is infected and it is walled off. That is what you're suspecting because there is no clinical improvement. Then you proceed towards an endoscopic or a percutaneous drainage. Also, sometimes when patients you have given these antibiotics, supportive care continued, and still there is clinical deterioration despite antibiotic and maximal supportive care, then you can consider an endoscopic or percutaneous drainage, even if there is no walling of mucosa. But this is has to be taken with a pinch of salt. You have to be very careful. Discuss with your gastroenterologist as well whether we should proceed for any sort of intervention. So you do an endoscopic or percutaneous drainage, but you got no further clinical improvement in 72 hours. If there's clinical improvement, well, and you just wait, continue your antibiotics, keep draining with the catheter. If there is no clinical improvement, you again proceed towards repeating a CCT. You again see whether these collections which you had put in a drain for have been drained adequately or not. If they have been drained adequately, but still your patient was not showing improvement in 72 hours, then you go either for a surgical step up or an endoscopic step up. This is what I wanted to tell you. You put in a catheter initially, then you proceed towards a step up approach, either in terms of a surgical step up with a ward procedure or with an endoscopic step up with an endoscopic transluminal necrosectomy. If these collections, if you saw, they got drained properly, but patient didn't improve, then you go for this step up approaches towards this. But if your patient has got a catheter, but these collections actually didn't drain, and that's why the patient didn't improve clinically, then you can think of upsizing this drain, or you can put in an additional drain as well. And again, if you see after putting this drain, you again go back here and see whether in next 7 hours again improvement, or you repeat the whole process again. And in all this process, you keep doing maximal supportive care for your organ failures. Organ failures are the things that the patient will die for, not for the actual acute pancreatitis for which the patient will die. And in this whole gamut of things, if you see at any point of time, you feel that there is some mechanical obstruction due to the complications of acute pancreatitis, and there is a walled off necrosis, you immediately again go for an endoscopic or percutaneous drainage. A mechanical obstruction is actually an intestinal obstruction that you're dealing with. So that time this pancreatitis has to be drained. There is no doubt about it. So this is the whole summary of the pancreatitis management, which you have to tell very clearly in your examination when asked. So the first will be within first week, that is day 1 to day 7 management. And then once you do that, you proceed towards the other weeks or beyond the week of management. So usually examiners will ask you that this patient, when you present the case of acute pancreatitis, they will ask you that which week of presentation is this of this acute pancreatitis. What is the week of presentation at your ICU? What is the week currently that you are treating this patient and you have presented the case to us? So remember, depending on the week of presentation, your management will change. So there are controversial things in acute pancreatitis. I will not deal much into it. Anti-inflammatory agents, enzymatic production reduction, and also then enzymatic so to ameliorate pancreatic damage, there have been several inhibitors. Trypsin has been tried quite a bit, but none of them have shown any improvement till now. So thank you for your patient listening. Any doubts you can put in the chat box.
Thank you, Dr. Rohit.
Welcome, sir.
The next presentation is by Dr. Samir.
Hello everyone. Am I audible and my slides visible?
Yeah, you're audible.
Yes.
Okay. So now coming to just a basic idea about dialysis machine. How do these machines work? Okay. So the blood comes from the patient to this machine and back it is purified or whatever, and then it goes back to the patient. So coming from the patient, as we know, anything going away is arterial line. Okay, so coming from the patient to the dialysis machine is a arterial line, and from, is my cursor visible?
Yes,
Yes,
cursor
sir.
is visible.
Cursor is visible.
Yeah. So blood from the patient. So just imagine the patient is here, okay, on the right side of the machine or screen left side. Okay, so patient is here, blood coming from the patient. This is your arterial line. It comes to the pump. Okay, this is the pump. Then from the pump, it goes to the dialyzer. This is the dialyzer. I hope you can see. It is partially visible. This is the dialyzer, and from the dialyzer, it goes back to the patient. Okay. So this part from the patient till the pump is called as the pre-pump. Okay. So pre-pump, it has many parts. It has many parts. We can have a pressure gauge to see the pressure of the circuit. So any leak or anything, we can know there is a fall in pressure, there is a leak. So from patient till the pump is called the pre-pump part, and from the pump till the dialyzer is called the post-pump part. Okay. So pre-pump can have your several parts like pressure gauge, an air trap. Here air trap is not there. We can have a sampling port. We can have a priming solution part from where the priming solution is provided. Then we can have air trap also, and a heparin flush. Here we can see this is your where the heparin is kept. Heparin is given into the in the circuit. This is pre. This can also be used as a sampling port. Here the heparin is given into the circuit. This is pre-pump. Okay, for maintaining the flow. Then this is your post pump. Post pump, this is your what is your called a air trap. This is upright, so any air bubbles in the flow or anything, it can is escaped from this into the atmosphere. So this is your air trap. Okay, post pump we have an air trap. You can also have your heparin introduced here in the post pump also. So and post pump can also have a sampling port. It also has it can also have a pressure gauge. So from here it goes to the dialysate. Okay, from the pump, this is the post pump circuit, then it goes to the dialysate. So from the dialysate, there is a countercurrent flow of dialysate fluid in this dialysate chamber. Dialysate fluid, there is countercurrent. So after it exits the dialyzer, then here again we have an air trap. Then this blood is returned back to the patient. This is your venous circuit. Okay. So again, this can also have a pressure gauge. This is, as I told you, air trap. So what all readings we can see here? Here, as I told you, there is the air pressure gauge. So we can see here the arterial pressure, venous pressure, and here the transmembrane pressure of the dialysate. So this is your conductivity. Conductivity is what your to know whether your dialysate fluid is perfect or not.
Sir, screen is not visible.
Which one?
Sir, the screen is not visible.
The
Sir, the
machine,
presentation is not visible, sir. Slides are not visible.
now is it visible?
No, sir.
Okay, my screen sharing has stopped. Sorry. Now?
Yes, sir, visible now.
Yes, sir. Visible.
So this one we had seen, no?
Not seen, sir.
This
Machine part seen,
seen.
sir. Machine part already done, sir. Machine part seen.
Machine part is seen, no?
Yes, sir.
Okay.
It got disconnected from the graph part, sir.
From this one?
Exactly, sir. Exactly.
Okay. So here what we have, my cursor is visible?
Yes, sir. Visible.
Okay. So here you see, this is your air detector. As I told, there is an air detector present. If any air molecules are there, it can detect and say the air traps are there to remove the air bubbles. This is a blood leak alarm. If there is any leak in the dialyzer, then this alarm will go. If there is a rupture in the membranes of the dialyzer, we can know. Arterial pressure, as I told, pressure gauges should be there in the pre-pump and post-pump to know if there is any leak or any rupture in the pipe. We can know the pressures. This is your transmembrane potential pressure. Transmembrane pressure is again to know if the dialyzer is choked or it is working fine. Okay, transmembrane is for dialyzer. Here this is conductivity. Conductivity is what the dialysate fluid is made from what? RO water, that we have RO water behind the dialysis machine, RO plant. So RO water, and there are two buckets as you saw in the previous week. You have seen in your dialysis machine, two buckets are kept. This is your bicarb, this is your acid. So these two fluids get sucked in from here and mixes with the RO water here, and that is run through the dialyzer against in the counter current direction to the blood flow. Okay, so that if any concentration gradient is different than the desired concentration gradient that is preset in the machine, okay, the dialysate fluid, if any mixed constituent, if there is more acid or more bicarb, then your the potential of the fluid that should be within the desired. If it is not there in the limit, then there will be an alarm. This is the ultrafiltrate. This is the flow rate. This is called the QB, blood flow rate. So the speed at which a blood is removed from the patient by the machine or by the pump. Okay, so here it is. We can see the 220 ml per minute. So 220 ml per minute blood is removed from the patient and brought into the machine by the pump. This is your heparin. So you can see how much of heparin bolus can be given. It is given during the priming of the circuit, then intermittent during the dialysis. Okay, this is the heparin. This is your heparin stand where you can fix the heparin syringe. Cursor is visible?
Visible, sir.
Yes, sir.
Cursor
Visible,
is
sir.
visible.
So this is where the heparin syringe is generally put. It can give automatic as you put the rate, or you can, the technicians generally give manually also. Now coming to the once you conductivity window. So this I told you the potential, the of the electric potential of the dialysate fluid. If it varies, if there is no proper mixing of RO, bicarb and acid, then this will show an alarm. We can know that the constituent fluid is not correct. Okay, so the what we can do is, this is the constituent of the dialysate fluid. Sodium is 135, same the prescribed sodium, same as our blood. Mostly it is isosmolar or just slightly hyposmolar. I will tell later. Bicarbonate, here it is plus or minus 0. You can make it plus 8 in case of severe metabolic acidosis. So more amount of bicarbonate solution will be aspirated by the machine in preparing the your dialysate fluid. This is the temperature of the dialysate fluid, which has to be maintained near body temperature. This is the flow of the dialysate fluid, 500 ml per minute. Now coming to the UF values, there was a UF button. Here we can see here UF on or off. Once you make it on, that will be ultrafiltered will be there. If you make it off, there will be no ultrafiltered. Now ultrafiltered, you can set only the goal. Depending on that, the UF time left depends on your time of dialysis that you have set. Accordingly, this will also change. UF rate will also change depending on the ultrafiltered goal that you have set. Okay, so you can set only the ultrafiltered goal. These two will, this is depends on the amount of dialysis left. This rate will depend upon the UF goal that you have set. Okay, so this is how a dialysis machine basically works. Any doubt on how it works, please write it in the chat box. Okay, now
Sir, there are some blood flow parameters now that can be also adjusted. apart from dialyzer flow parameters.
Yes, yes, this one I showed now in this one, blood flow parameters, this slide. Okay. Here I don't know QB is your blood flow, 220 ml per
Yes, sir.
minute.
Yes, sir.
So here you can
Okay.
increase or decrease depending on how you need, how much of clearance. That I will tell in the next slide. So that is why. Okay. So before I go into more of dialysis, little break, we will go a little into bit of cardiovascular, some viva. So you can all put on your mics for answering. So this is a aortic pressure wave trace of a 55-year-old man, 12 hours post CABG. IABP is present, but he has cold peripheries. Blood pressure is 90 by 45. He is oliguric and has lactic acidosis. Okay. So the A is your aortic pressure trace, B is your balloon pressure trace. So what describe the IABP trace here? Compare it with the aortic trace and describe the IABP trace. Anyone? Anyone wants to answer? Is it visible?
It is visible, sir.
Okay. Anyone trying attempting this? Okay, first tell me how is
I'll
it
post.
augmented? 1:1, 2:1, 1:2. What augmentation? Anyone would like to comment? See the aortic trace and see the balloon curve. How many tracing it is
Someone is
showing?
saying wrong inflation times.
Okay, very good. Why? Anyone would like to comment why is it 2:1, 1:1, 1:2, 1:3? When is it augmenting?
No augmented diastolic wave is seen. So 1:1. That's what he was. Somebody, Mr. Dr. R, want to say. No augmented diastolic wave is seen. 1:1.
Yeah. Is 1:1 or 1:2? See the waveform here and see the augmentation here. What you are saying is partially correct. That is the diastolic augmented pressure is equivalent to the systolic pressure. Okay, in the trace. Whoever has told that is correct. But the augmentation is 1:2 here. So what can be done to improve the circulation is make it a 1:1 augmentation. Okay. See here there is a during the dicrotic notch. Okay, there is the augmentation generally. Okay.
Yes, sir.
Uh-huh.
Kindly explain 1:1,
Uh,
1:2 needing, sir. That's what somebody is meaning. Somebody is asking what is
okay.
1:1, what is 1:2.
Okay. Okay. In IABP, what happens? See, IABP when there is your heart failure, cardiac index is very low. You are trying to augment the heart by IOBP. Okay, so that is diastolic inflating of the balloon. Whether you have to do it at every heartbeat or every. Is it audible? Hello.
Sir, actually the explanation. Can you repeat the explanation, sir? think there was some issue with the connectivity during when you were explaining it.
So what happens is that IABP means either aortic balloon pump, it augments your, because there is a diastolic failure, the patient that is a cardiac index is quite low, your IABP balloon pump, intra-aortic balloon pump, that is inflated in the diastolic to augment your cardiac contractility. And so depending on the heart rate, what you can do, the augmentation, it can take at place of each heartbeat or every second heartbeat or every third heartbeat. Depending on that, it is defined as the augmentation, whether it is 1:1 or 1:2 or 1:3. Okay, so that is what is augmentation of your cardiac 1:1. So here what we are seeing is your aortic pressure. This one you can see, as somebody pointed out, your augmented pressure, diastolic pressure is similar to that of your highest systolic pressure. From the curve you can see here there is a augmentation. Can you understand? This is your systolic pressure, peak systolic. Are you understanding who was asking? So the
Yes, the person who answered is yes, he's understanding.
Did
Yes,
you
sir, he
understand what
answered
is
is
1:1,
he's
1:2?
understanding.
Every
Yeah,
first,
he answered
how
is
many bits are augmented? That is 1:1 or 1:2 or 1:3? Yeah, okay. So the inflation generally occurs at the dicrotic notch. Okay, this inflation. Okay. So the diastolic augmented pressure should be at least equal to the end systolic. Here, as we are seeing, it is equal to the end systolic. Okay. So either it should be equal or it should be higher. Okay, but here you see why it is 1:2. This is one augmented. Here there is one bit which is not augmented. Then again the second one. Then again every alternate is augmented. Here again not augmented. So this is 1:2 instead of 1:1. Okay. Whoever answered 1:1, did you get it? Why is it 1:2?
yes, sir. He answered yes. He got the point.
So this is non-augmented. This is again augmented. This is non-augmented. This is again augmented. So it is 1:2. Okay, so but in spite of this augmentation of 1:2, his peripheries are cold, BP is 90/45, patient is oliveric, so there is not proper circulation. So now we have to increase the augmentation to 1:1. Got it?
I think the point has been taken, sir.
Okay, so that
by the audience. Yeah, sir. Please proceed. Yes, sir. Please proceed.
Okay, so now this is a 44-year-old woman presenting with shortness of breath. Any likely diagnosis? Anyone trying to attempt?
Pulmonary embolism, S1Q3 T3, and RV strain pattern.
Excellent answer. This is who? Anjali, I think. Who answered this?
Dr. Anjali, sir.
Yeah. So okay. So this is why S1 Q3 T3. So this is your deep S waves. Okay. Then in your 3, there is a deep Q. Okay. Then this is your T3. T wave inversion in 3. So S1 Q3 T3. All right. So this is a pulmonary embolism. This one. Anyone?
Pulsars alternance, electrical
Alternate
alternance.
P is followed by QRS complex.
So what is that? Before going to diagnosis, and the previous one also I missed. First, you have to tell the what you have to see first. In any ECG that were given, what you have to see the first thing? First, tell the rate and rhythm. Okay. So tell the rate first. How much will be the rate in this patient?
Around 50.
Yeah. So what is that? Is heart rate 50 in a 3-year-old or normal?
No, sir. Daddy.
So what is there present? Then see the P, QR, and S. Is every P followed by QRS?
No, sir.
Is every P, QRS, T, P, P, QRS, T, P, P. What is this? So what is this?
Fixed block.
Yes, this is second degree heart block, 1:2. Okay. Okay.
Yes, sir.
Did you get it? This is P. Is it visible my cursor?
Visible, sir.
This is P. My cursor is visible, no?
Yes,
Yeah,
sir.
P, QRS, T. This is P. There is no QRS. Then again P, QRS, T. Okay. So that is 1:2 block. That is prolonged QT interval. You can calculate the QT duration from here. How many blocks? More than just a little bit more than 4, 680 milliseconds. Okay. So what can be the possible causes? In a 3-year-old, so mostly this is a congenital problem. Okay. Although if there is means we can also have other drugs that can cause this, or if there is electrolyte imbalance like hypokalemia, hypomagnesemia, then this can also cause this. Okay. This one anyone going to try? ECG recorded after resuscitation in a 55-year-old man who suffered an out of hospital cardiac arrest.
ST depression and inversion in V2 to V5. That is NSTEMI.
Okay, somewhat better answer. T inversion is definitely whether which is your what is it called?
Delta wave.
Yes, very
Pre-excitation
good.
delta wave, sir.
Yes. Where is it
This
seen?
will be, sir, WBW syndrome.
This is a WPW syndrome. Okay. There is a wide QRS complex. V1 and V2 has a dominant R. Okay. This one leave it, not that necessary. Tell this this one you tell. ECG taken from a 77-year-old man present with dyspnea.
Sir, a PSTCG.
This is
PSTCG, sir.
yeah, very good.
Pacing is there.
ECG. What is the rate of the pacing? Rate of the pacing? How many squares? Around 4 squares. So 300 by 4, around 75. 75 is the heart rate. Okay. A 30-year-old man presents with a high-speed motorbike incident. This is the ECG. What is the finding? Because there is an RTA, there has to be something related to pericardium. Something will get accumulated in the pericardium. So the pericardium will be inflamed. So there will be pericarditis. So what changes are there? There's basically a right bundle branch block with a left axis deviation. Okay. Nothing significant changes except that.
I think there is
Until
small complexes QRS also, sir, suggesting tamponade and efficient. The complexes are very small in V4 and V4.
not very small.
That's it.
Your V2, V3, okay, you can tell small AVF V3, but A1 lead 1, 2, AVL, V2, V1, they are of normal size, V6. Depend on which part of your injury are present, accordingly there will be findings. Okay, so nothing
Okay.
significant here in this.
Okay.
This one, 65-year-old male with chest pain.
So pericarditis.
Yes, why pericarditis?
Convex upward ST elevation in all leads, all precordial leads.
Very good. So that is what in all leads. Okay, so that is a concave ST elevation. Okay, concave ST elevation in all the precordial leads. So that is why it is a acute pericarditis. Okay. Okay, so this is your concave ST elevation in all precordial leads. That is the acute pericarditis. Okay. Now this one.
Prolonged QT.
Very good. Prolonged QT.
Long
Okay.
QT,
But
long QT, yes, sir.
always remember to say the first rate and rhythm. Okay. Make it a habit. In exams, whenever you are asked, no, always go by the speed of first. Tell the speed. If name and is present, better rate and rhythm first. Then go to PQRS. Then the abnormality. Okay. Make it a habit. Don't directly jump into the conclusion. If you start saying that uh, speed of this much, your what rate is rhythm is this much, then the examiner will say no, directly tell. But if you miss it, they will get a point to point you out that why did you not tell this. Okay, directly. Always tell the rate first, rhythm first, then automatically we will come to the diagnosis. Okay, make it a habit. So this is prolonged QT syndrome. Very good. This one.
Complete heart block.
Very good. Cause of heart block?
Inferior wall MI.
Inferior wall MI. Excellent. Excellent answer. Okay, very good. Then what are these?
Sir, Matt.
Why mat? This is wide QRS or narrow QRS? What are these? Narrow or wide?
Narrow. Narrow.
Huh? Not
Narrow.
audible.
Narrow. Narrow.
This is narrow. What is this wave? What is this wave? This one? This one is narrow or wide? This one here?
This one is wide.
Capture wave.
See the lead 2, you will get the answer. Where should you?
Sir, atrial premature complex.
But this is your ventricular, no? Or not?
Sir, atrial premature complex, sir.
This is a ventricular premature complex. Which one? This one. What other findings are there? That will come to later. Any other findings?
Someone has answered as captured beat, someone has answered as fusion beat, sir.
No. What is the problem here? Here.
RBBB.
What is this? This one. Is it normal?
Inverted
P?
P. No. Inverted P. Low atrial complex.
This is a basically biphasic 2P. Okay, biphasic P. Okay. These are very minute changes, very difficult to actually appreciate. Here there is a biphasic P. Here there is a peak P in lead 2. Here this is a VPC is present. Okay. So this is a basically with left axis deviation present. This is the left anterior hemiblock. These are very difficult to appreciate. Don't worry. This one you should answer. That one you leave it. Tell this one.
Inferior valve stemi.
Only inferior?
Anterior inferior.
Posterior.
Why anterior?
V2, V3, there is V2, V3, V4, there is stimulation.
So what about V1? Is V1 involved?
Yes, sir.
Is V1 part of anterior lead?
Yes, sir.
V1 is a part of anterior lead.
Oh, no, no, sir.
Then 2-3 ABF changes are there, so definitely inferior. After that,
Also, sir,
V1,
3
V2.
ST elevation in 3 is more than 2, so RC editor is involved.
There is inferior definitely. V1, see, V1, V2 is involved means it has to be a septal, okay? Right? Okay, V2, V3, V4 is anterior, but if septal involvement is there, V1 involvement is there, V1, V2, V3, septal involvement may also sometimes include V up to V4 also, okay?
Yes, sir.
Okay, since V1
Yes, sir.
is involved, V1 when V1 is involved, it has to be got a septal. It can be anteroseptal, Okay, but here it is inferoseptal. Anterior it is good. You have told right V2, V3, V4 is anterior, but since V1 is involved, it is to be septal. So now can it be anterior also? It is told that if there is a septal involvement, it can also give changes in leads up to V4. Okay. So if V1 is involved, it has to be a septal. Okay. So this is a inferoseptal. Good answers. Very good answers. Now you tell me, a 47-year-old 90 kg man presents in shock after a large LED territory infarct. He is on ventilator, heparinized, receiving dopamine at 4.4, dobutamine at 5.5, heart rate is 125, BP is 75 by 65, IABP is present. Pulmonary artery catheter data are as follows. Okay. So suggest a possible diagnosis. See the data. Anybody? Answer is in the first three readings.
Somebody answered Elvis Stunning, sir. Elvis Stunning.
Stunning because of your infarct. Okay.
I think you want to tell something about LV failure.
Okay, LV stunning, LV failure. Okay, one can be one reason. Very clean diagnosis. There are some hints in the question. He has been heparinized and is receiving dopamine at 4.4, dopamine, tachycardia, BP, diastolic, systolic, diastolic is 76-65, very awkward, systolic by diastolic 70-65, IABP in situ, CVP, PA, POAP. First three readings will give you the answer.
Equalization of CVP, PAOP and the diastolic PA pressure, that is pericardial effusion tamponade.
Very good, excellent answer. Okay, so patient is heparinized. BP systolic is 76-65 is diastolic, nearly similar, very low pulse pressure. CVP 18, PA diastolic 20, POP 19, all very similar. So this is because of your tamponade. Okay. So further management, what has to be done in this? In this case, not of tamponade. I am not asking of tamponade. In this case, what you have to do?
Hold heparin and shift patient to the OT.
Very good. First thing you have to do in this patient is hold your heparin. Okay. Discontinue a heparin. All right. Very good. What other findings you may see in other tests?
Echo will show blood or fluid
Echo,
in
very
the
good.
pericardial cavity.
ECG, CVP
ECG, there will be small complexes and pulses alternance, electrical alternance may be there.
Okay, very good. Then CVP trace. CVP, what will you see? Tamponade. Anyone?
The CVP will be raised and
No, sir is asking about some C waves and V waves.
Which wave, what will be there, what will be not there in tamponade?
Prominent X and Y descent.
Prominent Y.
Absent Y.
absent
Y.
Y because filling will be
Absent Y. Excellent.
amplified.
The absent Y descent. Okay, very good, very good answer. So 58-year-old woman, history of hypertension and moderate aortic stenosis, scheduled for an aortic valve replacement. It was done post-operative. There are hypotensive episodes and a late systolic murmur. Echocardiography shows normal LV, no RWMA, EF 60%, RV function is normal, prosthesis is working fine, but your left ventricular outflow tract shows a reduced cross-sectional area during systole with obliteration of the chamber cavity. Okay, no evidence of pericardial effusion or clot. So why is this happening and what will you do for this? Anyone? Why is this happening?
Dynamic LVOT obstruction.
Yes. So very good. How will you proceed?
Reduce the rate, heart rate.
Reduce the heart rate. Heart rate is normal then.
Sir, fluids. Sir, fluids can be given. Fluids, hydration.
Who is telling this?
Sir, Shubhodip.
Okay. Anyone else? Okay, Subhadip is correct. Okay, so post systolic, you see what did I tell in the echo? Obliteration of chamber cavity. Okay, so maybe because of pre-op patient, because of severe aortic stenosis, patient was in fluid restriction or whatever, there is obliteration of chamber cavity after systole. Okay, so that is means what? Patient is in fluid deficit. You have to give fluid boluses to this patient. Okay, got it, everybody? Now, 45-year-old man presents with staphylococcal endocarditis involving the mitral valve. He undergoes surgical debridement and valve replacement. Prosthesis present. 1 week later, this is his blood count. There is cystocytes, reticulocytes, toxic granulation of white cells, reduced platelet numbers, large basophilic platelets. So he remains septic, mild splenomegaly, and systolic murmur is there. So why is the differentials of the thrombocytopenia and what is the final diagnosis?
TTP-HUS.
TTP-HUS. Okay. Okay, that can be. Anything else? Differentials. First, tell me three for differentials.
Hit.
Okay. And
sir, anemia due to mechanical valve induced hemolysis or.
Okay, very good. And toxic granulation is present, so
infection.
Sir, infection is present till
sepsis. Okay. So now we have our differentials. Okay. All are perfect differentials, good differentials. Now, how will you reach the diagnosis? Some info is provided to reach the diagnosis.
Platelet factor 4 IgG positive.
Very good, very good. What is that? So what does that indicate?
Hit.
So this is a heparin induced. Very good, excellent answer. Okay. So the differentials were also perfect. Every differentials were, and and because of the platelet factor 4 is positive, Ig positive, so that is why this is a heparin information. Very good, excellent answer. So 78-year-old, 70 kg man, chest pain, ECG changes with anteroseptal infarct. This is hypotensive, BP is low. Pulmonary artery catheter insertion is done, and this is the findings. So just interpret the data.
So low cardiac index with high SVR with high pulmonary perfusion pressure suggests of cardiogenic shock.
Cardiogenic, very good, very good. So cardiac index is only 1.6. Okay. And MAP, so there is shock. MAP is 55. There is cardiogenic shock. Cardiac index is 1. There definitely cardiogenic shock. Any other finding? Why is
Acidosis,
your
hypoxemia.
yes? Tell.
Sir, pH is low, acidosis and
Okay.
hypoxemia, sir.
Hypoxemia. Okay.
SpO2
And
is 85%.
why? What is the normal SbO2? What is written there? Of 75, 70 to 75, 75. Why is it high? How can it become high?
Low
When you have
extraction.
hypoxia, you need FiO2 of 0.6. Yes, yes.
When there is
Low
excess
oxygen
delivery or low
utilization.
extraction.
Low
Oxygen
oxygen
extraction
utilization.
ratio is better.
Low extraction due to cardiogenic shock.
Low extraction due to cardiogenic shock. Okay, good answer. Anything else?
Need Simenda or Dobu trial.
Okay, and that is the one correct answer. Then
Sir, milrinone or amrinone anodilators.
what? Patient map. What is your SVRI? Why do you need an inodilator? Your vascular resistance is high or low? Or normal?
High.
High, sir.
What is near normal? Don't need an inodilator at SVRI of 2250. What other causes can be of SVO2? In this case particular, anteroseptal infarct is a hint. What is SVO2? What is STVO2?
Intraventricular septal rupture, or there is a communication of the right sided and left sided.
Very good. There is a communication. I would have asked what is SVO2 and SVO2. Come on, there is a communication. Okay, intracardiac communication is present. Left to right shunt has to be there so that left blood goes into the right side, increasing the oxygenation of the SVO2. Okay, so because there is an anteroseptal defect, very likely the patient will have a ventricular septal defect. Okay, VSD present. Okay. If there would have been reduced extraction, it would have been about lactate and all. That would have been there. This is for examination purpose, not practical, so don't worry. It's not practical here. Okay, so correct answer. Okay, so there is cardiogenic shock, definitely low cardiac output. Now this one. 40-year-old woman, poor exercise tolerance. ECG shows sinus rhythm, tall R waves in V1 with right axial deviation. P pulmonale, T wave inversion V1 to V4. So what is the likely cause?
RV failure.
Pulmonary hypertension.
Pulmonary artery hypertension.
Pulmonary artery hypertension is a better answer than RV failure. Okay, why?
Right ventricular pressure is very high.
The pulmonary artery pressures is also
Yes,
POP.
all are very high. Your PAOP, pulmonary artery opening pressure, is on the lower side. So that is mostly pulmonary what? Because your POP is low, so the problem is in the pulmonary
cause.
circuit. Yeah. So pulmonary artery hypertension. Okay. So this is a nitric oxide provocation test. Your nitric oxide concentration increases your pulmonary artery pressure. So interpret the result and explain. Very easy.
So decreases with the use of nitric oxide.
So nitric oxide can be helpful in this. Which drug will be helpful in this patient?
Phosphodiesterase 4 inhibitors.
What is the mechanism of action? To initiate in this patient, seeing this, what will act through the nitric oxide pathway? That is why I asked.
Phosphodiesterase 4 inhibitors will promote cyclic AMP, which will cause dilatation.
But what is the then nitric oxide? Why we are trying to see? How is yesterday I told no? Inducible nitric oxide, which ions cause the overexpression of inos? Which ion? In post cardiac surgery shock, I had told yesterday. Okay, calcium. So here you will initiate patients on calcium channel blockers. Okay. Okay.
Okay, sir.
So
Yesterday class you had attended, then you could have made a correlation. Yesterday actually it was a very important day. All were busy there, so no complaining, no complaints. So Swan-Ganz data again. Now interpret this hemodynamic data. Patient is on dopamine and NORAD and has fever.
There is no decrease in
Yes.
pulmonary pressures.
What?
Pulmonary vascular
pressure?
stents are high.
So there is no decrease in the pulmonary pressure after nitric oxide.
So what does that mean?
It's not vasoreactive. It is not vasoreactive.
Okay. And there is significant, very good. That is definitely there. Okay. Pulmonary hypertension is there.
Obesity-induced pulmonary hypertension.
Pulmonary pressure increases after giving nitric oxide. Very good. That is definitely there. Another thing, cardiac output.
Cardiac output on the lower side, sir. RV failure, core pulmonary.
There are two cardiac output readings. Can you see? One is by thermodilution method. One is by esophageal Doppler method. There is a difference in both the readings. Again, why is that there? Yes. Why one cardiac output is higher? Thermodilution method. Thermodilution method, where does it measure? Esophageal Doppler, where does it measure your cardiac output?
Thermodilution, femoral artery catheter with a thermistor at that tip.
So why it is showing higher reading than your Doppler, directly measuring at the OT, LVOT? Similar to previous answer.
Because of vasopressor, sorry, inotrope effect.
So that will be there on both the parts, no? What extra volume is going into the pulmonary artery? Showing higher cardiac output. But that output is not present on the LVOT.
Paper. No idea, sir.
Septal defect, okay. Arterial septal defect. Okay.
Okay, sir.
Got it? Because of the arterial septal defect, there is a left to right shunt. So that is why with thermodilution method we are getting a higher output than your Doppler. Got it? The cardiac output is high, no doubt, because of your hyperdynamic circulation, because of your septic shock. Okay. All right. So now, okay, a lot of is present. I will try finding which one would you like to know first now? Dialyzer, about the dialyzer or about the dialysate fluid?
Dialyzers.
Go with the dialyzer, okay. Visible? Is it visible? Yeah, okay. So now coming to the dialyzer, it is a semi-permeable membrane through which your exchange of molecules and fluid takes place, that the dialysis that takes place, okay. So there are two ports you can see, okay, blood ports. These are the two blood ports. One is for entry, one is for exit, and here we can see two dialysate port, again one for entry, one for exit. So there is a counter current flow in this takes place in this dialysate chamber. So what happens here is there are many pores present, okay. So many pores are present, many chambers, that millions of chambers are present. This is just a cross section showing only one part. So blood flows through this pipe, and your counter current mechanism flows, your dialysate flow goes in this direction, okay, opposite direction. Blood this direction and dialysate flow takes place in direction. That is how, then that is because that is the cause of the exchange of molecules that takes place. So this is what happens. There are multiple pores. Once the blood comes inside, it goes into different chambers like this, okay. Many capillaries present, in the dialyzer, and this surrounding that the dialysate fluid flows in the counter current. Okay, clear? So basically the exchange takes place because of your diffusion. So here we can see diffusion, that there is higher concentration. This is your blood flow this direction, and dialysis is in this direction, counter flow again. That is high concentration of solute present here, the yellow particles. These are the smaller particles like urea and all. These are larger particles like beta 2 microglobin and other proteins. So the lower particles, they cross this semi-permeable membrane by the method of diffusion from higher concentration to lower concentration. The other thing that takes part in this exchange of solute is called the convection. In convection, what there is also fluid exchange takes place because of the concentration gradient. Along with that, these big protein solutes, they get dragged here. That is called your solvent drag. Okay, solvent drag of the solute. That is how our ultrafiltrate is created, as more fluid comes out from here, from this side into this side, along with the solute. Okay, that is called the solvent drag. So the large because of the hydraulic pressure gradient. Okay, large molecules like beta 2 globulin, they cross by method of convection. Okay, now this, okay, large molecules by convection. Now this depends on the pore size and the membrane surface area. The amount of diffusion takes place. More the area, more the diffusion. Larger the pore size, larger the molecules. Those are the get diffusion takes place from your blood into the dialysate flow. Okay, so these are the membranes. They can be, actually there are two type of membranes. They can be non-synthetic or synthetic. A non-synthetic is generally, that is natural. Non-synthetic is made up of cellulose. Again, it is two type of unmodified or modified. Unmodified is you're made completely of cellulose. Your modified is made when the hydroxyl group of cellulose is substituted by any different molecule. Now synthetic is generally made up of your polysulfone, okay, or polyethyl sulfone. Okay, just remember this much. Not the quality depends on your thickness. Okay, thickness of this sheet depends on your pore size. Okay, surface area available. This is for beta 2 microglobulin. These are what, because there are different types. The types of dialyzer, that can be low flux, high flux, or protein leaking. They depend on the, again, as I told, pore size and the thickness. Okay, so high efficiency dialyzer, they clear better protein than the your low flux dialyzer. Okay, so then there is your, this is called your coefficient. Earlier, the dialyzers that were used, the coefficient KUF varies for each molecule differently. For creatinine, KUF is different for a particular dialyzer. For urea, the KUF is different for a particular dialyzer. Okay, this is defined by the volume of fluid that is transferred per millimeters of mercury of pressure gradient. Okay, so that is what is called your coefficient. So it is different for each particle. Accordingly, the selection was done. But nowadays we fix the ultrafiltrate and the ultrafiltrate rate. So depending on that, the dialysis and ultrafiltration takes place. Now this is not this does not matter. So these are the factors that means the quality of dialysis depends on these all factors, as I told. The quality of the area, surface area, okay, the priming fluid, the pore size, pore diameter, and disinfectant used. Okay, now one more thing that I wanted to tell is, so there are the protein leaking, high efficiency dialyzer is where that higher amount of protein is cleared. Whether it is a high efficiency or a low efficiency or a protein leaking dialyzer, that depends on your beta 2 microglobulin clearance of each dialyzer. So higher the beta 2 microglobulin clearance, it is called, if it is very high, it is called protein leaking. If it is in the medium range, it is called high efficiency dialyzer. If it is on the lower side, it is called low efficiency dialyzer. Okay, this is how dialyzer works. Any doubt regarding dialyzer?
Any particular indication for high efficiency dialysis?
see, it depends on which molecule you want to clear, which kind of you are dealing with. Acute, you are dealing with uremia, or like your high means what do you call myeloma and all. Depends on which. Okay, multiple myeloma, like, understood, where beta 2 microglobulin are very high, right?
Okay, sir.
So which disease you are dealing with, what you want clearance of, what any your myeloma or any depends on your disease, which kind of clearance you want. Depending on that, you can choose your dialyzer. Okay, suppose there are any drugs which are bound to protein, you want to clear those drugs, then also you can go for high efficacy or protein leaking dialyzer. Okay, any poisoning. Okay,
Okay, sir.
any other doubt in dialyzer you can write. So this one ready? Is it visible?
Yes, sir.
Another 10 minutes will be done. Okay, 10 minutes. 68-year-old gentleman in ICU following AMI, coronary angiogram, left LAD and left LCX that was not amenable to stenting. So invasive ventilation for worsening pulmonary edema. He became more and more hypotensive. Pulmonary catheter was inserted. Dobutamine was going on. NORAD was going on. He has received fluids, 3.2 liters. Heart rate is 118. The sinus. Blood pressure is 78/52. So this is your PA findings. Okay. So what has to be done?
Stroke volume is 22 ml. That is patient in cardiogenic shock, IABP.
Yeah, very good. Stroke volume. Then cardiac index. Everything is basically low, right?
Yes, sir. Cardiac index, cardiac output map, high CVP.
Map is low. Everything is low. Pulmonary pressures are high. So what will you do for this patient? Patient is already on your NORAD and Dobut. Fluid has been given.
Insertion of IABP, sir.
Yeah, very good. So we will plan for insertion of IABP in this patient to augment the heart. Okay. So IABP insertion has to be done. Very good answer. So now IABP was inserted 1 hour after. This is the finding. So what changes should you make?
Sir, the augmented diastolic pressure is almost equal to the systolic pressure. It should be higher.
Yeah, very good. It should be higher. So what will you do?
We can reduce the ratio.
We can make 2:1 to 1:1.
Very good. Very good. Okay. Very good answer. So everybody could appreciate that your your systolic peak pressure assisted is the same height as your diastolic. Anybody could appreciate, everyone?
Yes, sir.
Yes, sir.
Huh? Okay. So 73-year-old patient from CABG, on pump CABG, hypotensive since return. Patient is a known diabetic, hypertension, mild emphysema. She has received 2 liters of colloid, but still on 0.25 microgram per kg per minute of NORAD. This is your PA catheter data. So what is the problem?
No, sir.
Same, sir. Equalization or of all pressures at the cardiac tamponade, sir.
But CP is normal.
Very good, very good, very good.
Hypo
Excellent.
hypovolemia goes towards low stroke volume with low
There is
CVP.
definitely blood loss, okay, but not in the
Hypovolemia.
cardiac. There is no tamponade effect in this. There is definitely blood loss. Okay, so the cardiac output is because the CVP is only 5. Okay, so there is very high. You see the drains or any intra abdominal wherever inside the body, there is a huge loss. So you have to give fluids and bloods. Okay, got it?
Yes, sir.
Very good, very good. Why not? Okay, there was no NTG. Okay. This one, born patient, 65%. There is esophageal Doppler. So this is the finding. So what is your next advice? Where is the normal FTC? Am I audible?
Yes, audible.
What is the normal stroke volume? What is the normal FTC? What is FTC?
FTC approximately 300 to 350 centimeters.
300 to 360. Okay, so this is low.
Yes, sir.
FTC is low. And your stroke volume?
Stroke volume 40 ml is low.
Is low. So what will you do next? The corrected flow time is low. Stroke volume is low. What will you do? Cardiac output is also lower at the lower side.
Hypovolemia. Volume.
Hypovolemia. So you will give volume fluid to this patient. Okay, very good.
Yes,
Okay,
sir.
so the cardiac output is low. Your FTC flow is low. Cardiac output stroke volume is low. So this hypovolemia, you have to give fluid to the patient. Okay, very good answer. Now you tell me, what is this peak velocity suggest? Just for a hint, peak velocity is low. So if the peak velocity is low, what does it suggest?
Cardiogenic.
Cardiogenic. Very good. So it is a cardiogenic cause. Also is present. So give fluids. You have to give anotropes. Because the stroke volume is low, cardiac output is low, FTC is low. So what will happen in only cardiogenic FTC? Cardiogenic shock.
FTC is inversely proportional to afterload, so his fare will be high, sir, in cardiac.
Yes. So that is what is differentiating here from fluid and cardiac. So there is a mixed type. Okay.
Okay.
This one just name. Start naming. What is this? Anybody?
Peak line. Peak line.
Peak line.
Very good. Peak line. Very good. This is a peak line. Okay. This one. What is this?
Sir, radial arterial cannula.
No.
Port vein, cannulation vein.
No.
Porta cannulation, sir.
Bone
No.
marrow.
Yes. Not bone marrow. What is that?
Intraosseous.
Intraosseous needle. Okay. So intraosseous needle. Where do you generally attempt intraosseous cannulation? Means during cardiac arrest. Okay, mostly. So
Okay.
which procedure
Tibial shin.
or where?
Medial aspect
Where
of
do you like
tibia.
to do? Very good. Tibia and little bit more specific. Where in tibia?
3 to 4 centimeter below the tibial tuberosity on the medial side of the
Why?
tibial shin.
Why?
The approach to the bone is quite superficial there.
And prevent injury to epiphysis. Okay. So you have
Okay,
to
sir.
go caudally. Okay. Direction of the needle should be caudal, 3 to 4 centimeter below tuberosity. Very good. Very good answer. Name one. What is one?
Balloon inflation, most distal tip.
Uh-huh.
For the balloon inflation, so most distal tip to measure the pulmonary pressure.
One.
One is this.
There are 1 to 10
Syringe.
numbering.
Yes, sir. One is
What is
the
that one
syringe
called?
to inflate the balloon.
Syringe? This is a syringe. What is typical about this syringe?
You can't load more than 1.5 ml.
1.5 ml. Very good. Excellent answer. Whoever is giving. Excellent answer. Okay. What is 2?
It was
So this is basically a pulmonary catheter. Okay. Pulmonary
yes, sir.
catheter.
Yeah.
So one is a syringe up to only 1.5 ml, not more than that. Very good. Two is. Can you tell why? Why 1.5 ml only?
Because inflating beyond that is not advisable. Can damage the pulmonary vessels.
Yeah, the rupture of that
Place we are
quickly. Very good.
inflating.
Okay. It can cause, the caliber of the pulmonary artery is very low. So if any higher volume, inadvertently also if you give very higher volume, there are chances of pulmonary artery rupture. So to prevent that, it can only be inflated up to 1.5 ml only. Very good. So what is 2? It's a sliding locking device. Okay. Just remember it's a locking device. Okay. Then
Okay,
three is about that marking. What does that marking tell?
Around centimeters.
Yeah, centimeters from where?
So from the tip, sir.
Yeah, from the tip. Okay. Very good. 4 is the
For thermistor attachment for temperature measurement.
that is your
And for thermodilation.
transducer monitor.
Yes,
Attaching
sir.
transducer. Okay. To the monitor. Then 5.
5 is the so for giving fluids, drugs.
Fluid drugs. Okay. Proximal
Proximal
injected.
port.
Okay. It is a proximal one. Okay.
Proximal port. Yes.
Yeah. And 6, 7.
6 and 7. So I think it will lie in the right atrium. We can measure the CVP. We can give fluids.
Yeah, that is the P. Which one is the CVP out of that? There are two colored lumens. Okay, white and yellow. Which one is the for the CVP?
White one. White one, sir.
No, yellow.
Okay.
So the distal one. Yellow is a distal one. Okay. It says that this is the yellow that completely comes till here. Okay, so that is yellow is what measures the readings. Okay. Then what is 8? This one.
Thermistor.
Thermistor. Very good.
The temperature.
Very good. Then 9 is your lumen only, this catheter. Okay. And 10?
Okay. Distal most port with the balloon.
That's the balloon, yeah, right. Okay. Very good, very good. This one?
Central line.
No. The answer is in the company name written there.
So pulse counter
One
and
transducer, one lumen.
cardiac.
What is it? Cardiac
or cardiac monitoring, sir.
Pacing wire.
No.
Pacing insertion.
No, no. Cardiac output monitoring is correct, but name the machine. There is a transducer. There is only single lumen.
Pico.
This is your guide wire, okay. This is your cannulation,
Pico,
whatever. This is your transducer, yeah, Pico, okay. Pulse
Yes, sir.
contour, continuous cardiac output analysis, okay. All right. This is a Pico. What is this one?
Esophageal Doppler.
Esophageal Doppler. Very good. So here are the findings. FTC is normal, everything is normal here. Okay. This one?
IABP.
Yes, this is IABP insertion. Okay, very good. This one?
Swan guns. Pulmonary catheter only, sir.
PA catheter.
With what extra is there here? What is this? What extra thing is there?
So pacing.
Very good. Okay. There is a pacing along with PA catheter. There is a pacing present. Okay. Very good answer. So coming to last, just about the dialysate fluid, I will tell something. You want to know about it, or will end?
Sir, continue, please.
Sir, please continue.
The dialysate fluid, okay. So dialysate fluid, what happens? As I told, you remember the first picture of the dialysis machine I showed? There were two containers in front of the dialysis machine. One bicarbonate was written, one was written acid. Okay.
Acid.
One is acid, one is acid. Then it mixes with the RO water. Okay, so that is how the dialysate fluid is prepared. So again, that bicarbonate mix and the acid mix, how are they prepared? So the dialysate fluid is prepared in such a way that that is mostly isotonic or a bit hypotonic. Okay, from our body osmolality. Okay, so the components are sodium, potassium, calcium, magnesium, chloride, bicarb, and dextrose. Okay, now in the dialysate flow, out the potassium can be varied. Okay, you have heard when you do a potassium free dialysis for K4, K8. Have you heard? While advising dialysis, we generally advise if the patient is a persistent hyperkalemia, is a CKD patient with persistent hyperkalemia, we generally advise for a potassium free dialysis. So the constituent of the potassium in the dialysate fluid can be altered, can be kept low depending. So there are some potassium free salts available to prepare your dialysate solution. Other thing, they have mostly similar concentration of these salts as to our plasma, except for phosphate and magnesium, because generally CKD patients, they already have hypermagnesium and hyperphosphatemia. So except for magnesium and phosphate, other constituents are more or less similar to that of plasma. Okay. So there's a decontaminant, obviously it is present. Okay. So bicarb. So your dialysate fluid is made up of a bicarb and acid. Okay, so that is to reduce the pH. Higher number of bicarb, more bicarb solution is taken, so to reduce the pH is increases, and if more of acid is present, your pH decreases. Okay. One thing which I wanted to show, okay, that photo, the dialysate flow. What happens is mixing. What happens? There are one bags of salt present. Okay, one is acid bag, one is your salt bag, your alkali bicarb bag. Okay, each bag is to be mixed with 50 liters of water. All right, that bag photo I have with me in a different. Okay, there is a video channel you can watch there. I will give the link afterwards. Okay, one packet is used to be mixed in 50 ml of water, RO water. Okay, RO water to prepare acid and bicarbonate solution. Now those two, they are okay bicarb. 50 ml, 50 liter of water, one packet, and in 50 liter of water, one packet of acid is mixed. RO water comes from behind. Okay, the proportion in mixing is 1 part of acid. Remember, 1.83 part of this solution, 1 part of acid solution, 1.83 part of bicarb solution, and 34 parts of RO water. That is how the constituent of dialysate fluid is made. Okay, got it? Dialysate fluid. How is it made? There is a two salt bags different. It is mentioned there. Bag A, bag B. Bag A is your acid bag. Bag B is your bicarb bag. On that salt bag, it is written A and B. It is written in how much of fluid is to be mixed. So it has to be mixed in 50 liters of water each bag, and this is prepared. So here water is this bicarb and acid is sucked through these pipes, and here it goes and mixed with RO water, and the dialysate is then prepared and then sent to the dialyzer through this port, and it exits from this port and it goes into the drainage pipe present in the backside of the wall. Okay, that is how the dialysate is made. So bicarb acid 1 part, bicarb 1.83, and 34 parts of RO water. That is how your dialysate is made. Okay, so that is all for today. Any doubts?
No, sir.
Okay.
Sir,
So we'll
this
end for
acid
today.
in bicarb bag, should that always be prepared manually, sir?
Our setup, it is prepared manually. Okay, I think pre-mixed solutions are available, but there are chances of contamination and all, I don't know. But after it is mixed manually by our dialysis technicians. Okay, so why there is no fear of any improper mixing? Are you worried about the improper mixing?
Yes,
Or
sir.
for what? Huh?
About the composition.
The fluid, no, composition, if they mix it wrong.
Yes, sir. Yes, sir. That was the
They are
doubt.
worried. If you remember, during the dialysis machine, I told there is a conductivity alarm, right?
Yes, sir.
You remember? If they mix it
Yes,
wrong,
sir.
okay, so the electric potential of that fluid, that will vary. This conductive alarm you're seeing here, conductivity alarm.
Yes, sir.
So if you mix it wrong, it will, this conductivity window, okay, somewhat there is a gap. I know there will be some spillage or something like that. So some mixing of here and there, your RO water also may not be always pure. So this is where this margin is given. So between this, they allow, once it is allowed, beyond that it will give an alarm that it is not your dialysate fluid is not properly prepared. Okay.
Okay, sir.
Any other doubts?
If the conductor alarm is there, then the only option is to change the bag, sir, or prepare the new
Yeah,
solution.
you have to make a prepare fresh constituent of dialysate fluid. If there is an alarm, that means something is not properly prepared.
Yes, sir.
Okay, if RO water, they have to use RO water, because if RO, instead of RO water they use any other water, what they can do is prepare wrong. They can dilute lesser amount of salts and all to save or whatever, but lesser salts, so electrical potential, that will change your damage, the means the alarm will be there. So they cannot do that. Regarding whether RO water is being used or not, if they do not use RO water has generally no minerals. Okay, reverse osmosis. So if the minerals can clog and damage your deposits, your normal water can have many hard, means many salts which can deposit on the dialyzer surface and can damage it. So your transmembrane pressure will also increase and give alarm. So that also that they cannot be done. They have to use RO water. Got it?
Okay, sir.
Favored of minerals. So even that also they cannot do. Got it? We saw one transmembrane potential also, didn't we?
TMP.
TMP, yeah, right. This one TMP. Got it?
Is
This one TMP, transmembrane pressure. So if there is extra salts other than what the normal that permits smaller particles, other salts, they will get deposited. Like in water, we can have several impurities. They get deposited in the dialyzer membrane, and that will clog them, and there the transmembrane pressure will be high. So there will be again alarm. Okay. Any other doubt?
Sir, any particular troubleshooting if TMP is alarming?
If the TMP is high, you have to change the dialyzer.
Okay, sir. Okay.
They see depends on setup. There are some centers who they just reuse dialyzer. I think those who undergo regular dialysis, they have their own dialyzer that is washed in the. Do you know that? That they reuse the dialysis.
Sir, generally there is a machine, Renal machine, in which the dialyzers are washed.
Yeah. So dialyzer reused. They actually wash in that. If there is any clogging or what, they put another reused dialyzer or something like that. In our ICU, we have strictly told them to use a new dialyzer every time a dialysis is done.
Okay, sir.
More detailed about this dialysis machine and dialyzer fluid is present in our channel in YouTube. You can see there. I have mentioned there. It's a 10-minute videos. Here I told in short only because of time constraint. It is there. If you want, you can see. Okay. We have a channel, CCM Academics. Do you know? Are you aware of it?
Yes, sir. We are aware of it.
Yeah. Okay. Any other doubts?
No, sir.
Okay. So we shall leave for today.
Thank you, sir.
Yeah. Thank you. Thank you very much. Good night, everyone. So see you next week. Any suggestions or any recommendations? Definitely, please write in the WhatsApp group. Okay. Any topic that you feel has been left out that you needs to be covered. I also thought of preparing GI questions, but I think everything was covered. Were there any topics not covered that would have? If you want, I can do GI questions also, practical aspect. Okay, so we'll leave. Thank you. Good night.
Thank you, sir. Good night, sir.
Thank you, sir.
Thank you. If you want any topic, write it in the group.